الأوروبية للمسالك البولية، وعضو في الجمعية أو الرابطة العربية للمسالك البولية. أيضا هو كلينيكال انستراكتور في ويل كورنيل ميديكال كوليدج قطر، وريفيور ان Arab Journal of Urology، وهو مدير الكورس المتميز في مؤسسة حمد اليورالي كاثترايزيشن كورس، مديرنا طبعا، وأيضا lecturer in voiding dysfunction field in international meeting. حظينا بفيجر يعني من عالمي في هذا الكورس، وأنا واثق من الاستفادة الكبيرة التي سيستفيد منها الجميع. أيضا معنا الدكتورة هناء الحوثي. الدكتورة هناء الحوثي هي أول فيميل يورولوجيست إن قطر، وهي من القلائل في هذا المجال في بالنسبة يعني الفيميل دكتورز. هي حاصلة على البورد العربي في المسالك البولية في العام 2011، وحاصلة على الزمالة في الفويدنج ديسفانكشن من كندا من University of Western Ontario، وأيضا ماجستير في العلوم الجراحية أيضا من كندا. حاليا ترأس الدكتورة هناء وحدة الفويدنج ديسفانكشن في مستشفى حمد، وتدير برنامج الزمالة في مجال الفويدنج ديسفانكشن and female urology. ستكون المحاضرة الأولى للدكتورة هناء. الميكروفون معك دكتورة، تفضلي.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. شكرا دكتور شكري. نشكر الجمعية القطرية للأطباء، نشكر كل المنظمين، الأخت مريم العمادي، الدكتورة مريم العمادي، نشكركم جميعا جزيل الشكر، ونرحب بكل المشاركين في هذا الويبنار. We would like to welcome you all in this webinar. I hope you will learn and enjoy the learning about urodynamic studies. I understand that urodynamic is a bit difficult. That's why I, together with Dr. Ardalan, tried our best to keep the presentation as simple as we can. And I'm sure I'm speaking on behalf of Dr. Ardalan also in advising all the participants in this webinar to start practicing whatever skills you acquired from our presentations. Because urodynamic is like any other investigations. If you didn't practice it, even if you feel and think you learn everything now, if there is no practice, you will not master the skills. The first lecture will be about the basics of urodynamic, which is the component and indications of urodynamic, and we will quickly mention a classification of different voiding dysfunction.
ملاحظة للزملاء أثناء المحاضرة، يرجى أنه إذا من لديه أي أسئلة يكتبها في الجزء المخصص بالquestions and answers، ثم إن شاء الله وقت الدسكشن سنطرح الأسئلة على الدكتورة لترد عليها.
So we will start. What is the urodynamic and its indication? We will talk also quickly about functional and anatomical classification of voiding dysfunction in relation to urodynamic testing, component of the urodynamic study, then the analysis and interpretation of urodynamic. According to ICS, urodynamic is a measurement of physiological parameters relevant to the function of lower urinary tract system. It aims at reproducing the patient's symptoms while making precise measurements in order to identify the underlying causes. It's a quantitative measurement that may be supplemented by imaging like X-rays, and what we called as video urodynamic. What are the indications of urodynamic? It should identify or rule out factors contributing to the dysfunction we have in this patient, specific patient. It should obtain information about other aspects of lower urinary tract dysfunction apart from the main complaint of the patient. It can help us in predicting the consequence of dysfunction on the upper urinary tract, which we are always worried about. It helps us in the management by predicting the outcome, confirm the effect of treatments, and if there is any failure of previous treatment, through urodynamic, we can understand the reasons for this failure. Important notes, we have to keep in mind, in urodynamic suite, we read urodynamic graph. However, in the clinic, we don't, because urodynamic is a one piece of the whole puzzle. And we should define a certain questions before we request for the urodynamic. This way, I will explain it in my next lecture, that urodynamic will answer those questions. And for this, we sometimes customize the urodynamic study according to the patient's symptoms and conditions. So sometimes I will only request, which is maybe it's not so frequent, but we will only request the filling phase. After the filling phase ends, if the patient couldn't void, we doesn't care, because the specific question, the answer, we should get it from the filling phase. Also, we have to remember that failure to record an abnormality does not always rule out its existence. Basic physiology, of course, is essential for understanding and reading the urodynamic graph. Classification of voiding dysfunction related to urodynamic, not in general, just related to urodynamic. There are the classification, there are two classifications, functional and anatomic classification. The functional, either the dysfunction is related to storage phase, so the patient failed to store urine, or emptying phase, the patient failed to empty the bladder, or it's a combined. However, in anatomic classification, it's either related to the bladder dysfunction, to the bladder itself, so there is an overactive or underactive bladder, or related to the bladder outlet itself. So it will be overactive or underactive, or it will be combined bladder and bladder outlet dysfunction. The component of urodynamic studies, the cystometrogram, or what we call CMG, sometimes you call it filling phase, which is a measurement of the relationship between the pressure and the volume of the bladder. We check usually in the filling phase the sensation, compliance, capacity, competence of sphincter, and stability of the detrusor muscle or the bladder muscle. Pressure flow study, which is the second phase, or sometimes you call it voiding phase. This is a measurement of the relationship between the pressure and urine flow rate. So in the filling phase, it's a measurement of pressure and volume of the bladder, because we are filling the bladder. And the voiding phase, it's a measurement of the relationship between the detrusor pressure and the urine flow rate. In this phase, we assess the PDET at the PDET max, which we call it the pressure, the maximum pressure, and the PDET at Q max, which we call it the pressure at maximum peak flow with the complete emptying. This is two important terms: pressure at maximum, or the peak flow, PDET at Q max, which is the detrusor pressure at maximum flow rate. And this is, as we're going to see later, useful in calculating the bladder outlet obstruction index or the bladder contractility index. However, the maximum pressure, which is the PDET max, or the peak pressure during the voiding phase, this is the maximum value of the measured pressure. Electromyography, EMG, it's a measurement of striated sphincteric muscle function, usually through a surface electrode, which is most common, or needle electrodes. Urethral pressure profile, the last component of the urodynamic study, it's a measurement of the urethral pressure, which is the fluid pressure needed to just open a closed urethra just before the voiding phase. Sorry. We use two catheters we are using, cystometric catheter, which is of two types, either air-filled or water-filled, according to the system you have in your suite. We have it's usually size 7 French for adult. Maybe in pediatric we use 6. We call it the intravesical. Now, starting from now, I will say the intravesical catheter, and it's in the program in the graph. It will be abbreviated to PVES. The rectal catheter, usually it's a size 8 French catheter. Either we put it in the rectum or the vagina, or sometimes in rare cases we use it through the stoma if the patient has a stoma, and it is abbreviated as PABD in the graph. This is our urodynamic suite in Hamad Medical Corporation. You can see there is it has a special bed. This bed is can be adjusted for putting the catheters to the patient, and while supine position. Then it can be adjusted to a sitting position, so it will be more convenient while filling the bladder. And here we can see the cone here, so the patients can immediately void. Here is the tower that's connected to the urodynamic, and this is the urodynamic machine. We have it from Labori company. So analyzing and interpretation. This is a picture of the graph, how the graph look. However, sometimes, as we're going to see, especially in the next lecture, you will have different graph with different color codes. The most important before you analyze or interpret any urodynamic graph to check the lines. So here, this is the vesical pressure. This is the abdominal pressure, and this is the detrusor pressure. The detrusor pressure usually is calculated automatically through the software by subtracting the abdominal pressure from the vesical pressure. This is the EMG. This is the line for the EMG. This is the flow. And this is the volume voided. So we will start with the filling phase. Filling phase has, as I mentioned before, pressure, capacity, sensation, compliance, and detrusor overactivity. This what we are looking for in a filling phase. So the PDET should remain near 0 in filling phase. If there is any true rise in PDET, it will be one of two, abnormal. This is abnormal rise. Either it is a detrusor overactivity or loss of compliance. And if this increase was associated with a problem of the sphincter, we will have a urine leak. There are two important leak point pressures: the abdominal leak point pressure, which is ALPP, as abbreviated as ALPP, and the detrusor leak point pressure, abbreviated as DLPP. The ALPP, simply, it is the intravesical pressure, intravesical, at which urine leak occurs due to an increased abdominal pressure with no increase of detrusor pressure. So in the absence of detrusor contraction. And whenever you have this ALPP, this means that the patient had a urine leak at an ALPP of, for example, 80 or 90 centimeter water. So now you have a diagnosis of urodynamic stress urinary incontinence. And this ALPP is a measure of sphincteric strength. The lower the ALPP, the weaker is the sphincter. So this is the classical teaching that if the ALPP is less than 60 centimeter water, this means that there's a problem with intrinsic sphincteric dysfunction. If it is between 60 and 90, this is equivocal. And if it is more than 90, mainly the dysfunction is a urethral hypermobility, may or may not be associated with intrinsic sphincteric dysfunction. The DLPP, this is the lowest detrusor pressure at which urine leak occur in the absence of detrusor contraction and with no rise in abdominal pressure. Whenever there is a decrease bladder, this will lead, to decrease bladder compliance. And this has happened in case of bladder surgeries, radiation, severe wet overactive bladder. When the urethral resistance increase, this means that the DLPP increase. Why this is important and significant? Because if the DLPP is more than 40 centimeter water, there will be a hydronephrosis, vesicular reflex, and risking the upper urinary tract. We can see here, this is an X-ray showing a patient with bilateral VU hydronephrosis and VUR. Regarding the capacity is that we measure during the urodynamic is functional capacity, not the anatomical capacity. And usually we can expect the capacity before we are doing the urodynamic according to the voiding diary itself. And it is usually evaluated in the context of patient's complaint and history. The sensation, we check usually a 3-point sensation. We have a first sensation, which is the patient will become aware now of presence of urine. It is either when we reach 1/3 of the bladder capacity. Some book says it is when we reach 50% of the bladder capacity. Then we have the first desire to void, which is the desire, the normal desire to void when the patient has full bladder on the next convenient opportunity. So he can postpone it. The third point is the strong desire to void, that the patients need to go and void within a few minutes. Sometimes it will be reduced, the sensation, or absent. Usually this is in case of neurological dysfunction. Or sometimes we'll have non-specific bladder sensation, like the patient will say, and those especially spinal injury patients, they will have a headache or a vague abdominal pain. And sometimes the sensation will be pure bladder pain, which we see usually in case of interstitial cystitis. The compliance is the relationship between change in bladder volume and change in detrusor. So it's volume over the difference of pressure, and we measured it in milliliter per centimeter water. Causes of impaired compliance: there is an increased outlet resistance. For example, long-term bladder outlet obstructions or cases of spinal cord injuries or lesions. And as we mentioned before, if the storage pressure is more than 40 centimeter water consistently, this is will be risky for the upper tract. And in the graph, as we're going to see, there will be a slow rising in detrusor pressure. We can see here. So this is the vesical pressure. This is the abdominal pressure, and this is the detrusor pressure. I'm sorry about this line. I'm trying to figure out how it does occur. So we can see there is a rise in both the lines of vesical pressure and detrusor pressure. However, the abdominal pressure is almost silent. Lastly, in the filling phase, the detrusor overactivity. The detrusor overactivity, it's either spontaneous or provoked. It's either neurogenic or idiopathic. And usually we interpret the DOs in the context of the patient's symptoms and condition, because it's reported in up to 18% of asymptomatic volunteers, they found a detrusor overactivity. And in the graph, we will find a rise in detrusor pressure and P vesical lines only, with no rise in the abdominal pressure. As you can see here, so always check the line. This is vesical pressure, this is abdominal pressure, and this is detrusor pressure. We can see here, this is the rise, this is the first wave. Abdominal pressure is silent, and detrusor pressure, there is a wave. Then it came back, then there is another rise. You can see that the abdominal pressure is completely silent. And here, the second rise, both vesical pressure and detrusor pressure. Abdominal pressure is still silent. This is a good example. This is from our urodynamic suite. We can see the EMG is starting to fire. This means that the patient is trying to hold and stop if there is any urine leak occur. Usually this DOs occur in lesions above the brainstem, like CVA or overactive bladder, or sometimes occur in overactive bladder, or if there's complete spinal cord injury from T6 to S2. Now the voiding phase. For the voiding phase, we assess the detrusor contractility and the bladder outlet resistance. The detrusor contractility, we can say that the normal detrusor function is when there is a voluntarily initiated continuous contractions leading to complete bladder emptying within a normal time span. If there is a reduced detrusor activity, which we call detrusor underactivity, there will be a reduced strength and or the duration of the voiding, leading to prolonged bladder emptying and or a failure of complete bladder emptying. A contractile detrusor, it is when you fail to see any recorded or any rise in the detrusor pressure during the voiding phase. We have the bladder outlet obstruction index and the bladder contractility index. As we said, the bladder outlet obstructions index, it's usually in the urodynamic, it's calculated automatically. However, you can calculate it yourself by measuring the PDAT at Qmax minus 2 times Qmax. If it is more than 40, this signifies obstruction. If it is less than 20, this is non-obstruction. And if it is between 20 to 40, this is equivocal. You have to read it within the context of the patient's symptoms. The bladder contractility index, you can calculate it manually. It's by PDAT at Qmax plus 5 times Qmax. And this is simply a measurement of the strength of the bladder muscle. So if the bladder contractility index is more than 150, this means that this is a bladder with a strong contractility. If it's between 100 and 150, this is normal. If it is less than 100, this is a weak contractility. So here we can see, so this is the vesical pressure, this is the abdominal pressure, and this is the detrusor pressure. This is a clear example of obstruction because you can see there is a rise in the detrusor pressure reached 50 or 57 in one point. This is the urine flow, this is a low flow. So this is high pressure flow, classic of obstruction. And this is the abdominal. This should be more or less silent, but the patient, we can see that he is straining. He's trying to empty the bladder. This is another example where the patient is trying to, by straining and good straining, he's trying, you can see. And here in the detrusor pressure, it's only a minimal rise. And the flow is silent. The patient could not flow, urinate. So in a summary, urodynamic study is a dynamic study of the transport, storage, and evacuation of the urine. It aims at reproducing the patient's symptoms while measuring important parameters to reach the diagnosis. Clear indications and specific questions are always essential. There are two phases, filling phase and voiding phase, or sometimes you call it CMG, pressure flow study, PFS. In filling phase, we assess sensation, stability, compliance, capacity, and continence, or the sphincter function. In voiding phase, we assess contractility and bladder outlet function. Normally, detrusor pressure during the filling phase should remain near zero. If there is any true rise in detrusor pressure, this indicates either detrusor overactivity or low compliance, and this may be accompanied by urine leak. Capacity can be expected according to the voiding diary prior to the urodynamic study. If there is abnormal bladder sensation, you should note it during filling phase and relate it to the clinical condition of the patients. Compliance is a relationship between change in bladder volume and change in bladder pressure. Low compliance can lead to upper tract deterioration. Detrusor overactivity can be idiopathic or neurogenic, and it should be interpreted in the context of patient's clinical symptoms. Normal detrusor contractility during voiding phase should be voluntarily initiated to completely empty the bladder. Bladder outlet resistance can be evaluated with the help of BO index and bladder contractility index. Thank you.
شكرا دكتورة هناء، شكرا جزيلا على المحاضرة القيمة الرائعة، وأيضا الالتزام بالوقت، لا ما هو أكثر من ذلك، يعني أقل من الوقت المحدد. الآن عندنا فرصة للنقاش. في أسئلة، الأمانة هي قليل من الأسئلة، لم نتوقع الأسئلة أكثر، ولكن احتمال بالفترات النقاش القادمة تكون هناك أسئلة أكثر. في سؤال من الدكتور مالك أحمد يسأل عن what is the anatomical position of EMG electrodes. دكتورة هناء معنا؟
أيوة. Usually we put them, as I mentioned, they are either electrodes, patches or needles. Most commonly used in many centers in the world is the patches because it's more convenient. The needles, especially if you try several times, it will be painful and it may affect the voiding phase. And usually we just put it near the anal verge because this site will give us a close, true idea about the sphincteric function.
أيضا سؤال من الدكتور محمد عباد بيسأل عن what is the normal value of first sensation in adult.
Yeah, as I mentioned, some books said it is when the bladder reach 1/3 of the capacity of the expected capacity. So if the patient capacity is 450 or 400, we may expect it at 120, 130. And some books said it is when we reach 50% of the bladder capacity. So it depends on the bladder capacity of the patient. There is no absolute value.
Okay, Dr. Hussam يسأل عن if can be done in for children.
Yes.
The urodynamic study.
Yeah. So urodynamic study can be done for a pediatric age group. However, if the patient is less than 4, 5, if he is less than 4 years old, we do it sometimes under sedation. So the pediatric section will sedate the child, and they will send him here or send her here, and we will do the urodynamic study. However, we lose the information we get from the voiding phase because the patient is sleeping. However, above the age of 5 or 6, usually the child is cooperative and we can do it. Yes.
اوكي، في سؤال آخر بس كنا نتمنى من الدكتور لأنه اسم التليفون LTC 1400 احنا نبهنا أن تكون الأسماء هي الأسماء الفعلية الحقيقية، رجاء تعديل الأسماء. عموما السؤال يقول does urodynamic study need sedation or analgesics in adults؟ يعني يقصد.
No, in adults, no. There is no need for sedation. The insertion of the systometric catheter can be a bit annoying, but not painful. And the rectal catheter is also a bit of inconvenient. However, with the use of local xylocaine, local anesthetic, we give the patient a few minutes, then we insert the catheter. As I said, the catheter size is 7 or 6 in pediatric, and there is no need for pain management. And usually we ask the patient, he can sometimes go after he finish, he can resume his daily activity. Some of them will go back to their work with only instruction of drinking plenty of fluid that time.
Okay, سؤال من الدكتور لطف الله غليس: how to prepare patient for urodynamic to avoid artifact?
Usually the artifacts occur when there is, for example, a lot of movement. So as I showed before, the stretcher, we have a special bed, so the patient can be in supine position while we inserting the catheter. You have to have a good technician, because a good technician which can handle the catheters, both systometric catheter and rectal catheter. Then you do the flushing well. Also, this is depending on the technician or the nursing. We ask, then after the patient is sitting, we make sure that all the graph are correct. There is a good conduction from the catheters. And every now and then, almost every 1 minute, we will keep checking. So we will start the urodynamic with no artifact. Then during the urodynamic study, after each minute, we'll ask the patient to cough just to check. Still, we have a good movement in both catheters or no. So if there is any abnormality, we will hold the test. We will ask the technicians or the nurse to check where is the problem so we can resume the urodynamic study.
دكتور إبراهيم النظاري يسأل في حالة ال VUR or large diverticulum, is there any special tricks in patient with these cases?
He means after the TUR?
No, يعني patient with severe VUR or large diverticulum.
VUR, I thought TUR.
Yeah, vascular reflux.
Okay. So in case of VUR, so he's talking about conventional or with the video urodynamic?
I think with conventional.
So no, usually there is nothing apart from if I'm expecting, if the patient had, for example, ultrasound and there is reflux, and if the hospital has the facility of video urodynamic, so it's better to run it with video urodynamic. So you can see the reflux. Is there a reflux only while voiding? You take x-rays while voiding, or it's severe to the degree that even during the filling phase there is a reflux?
I think he mean the estimation, the correct estimation of the capacity of the other parameters, because due to VUR it would be different.
So
or not real.
Yeah, but this is what I'm saying. So if I know beforehand that there is a VUR in this patient via ultrasound, I will, and plus the voiding diary, of course. If the voiding diary, the patient is bringing voiding diary with a bladder capacity, he's passing only 200, 250 or 150, yes, I will expect that the capacity is increased, is more than that. But during the urodynamic, I cannot push above, so I will say, okay, this is the 300 or 400 true anatomic capacity, I will push more. No, we said the capacity we estimated during the urodynamic is the functional capacity, not the anatomic capacity.
Yes. دكتور مالك أيضا يسأل عن الuse of anticholinergic and its affect the real urodynamic study results.
Okay, so this is controversial. It depends. Are you doing the urodynamic to diagnose overactive bladder and DOs, or to check is the anticholinergic or whatever modality of treatment you use is effective? Depending on the facility itself, so, and even the doctors themselves. So, for example, between me and Dr. Ardalan, I don't ask the patient to stop the anticholinergic. If I want for some reason, for any other reason, to do urodynamic after starting the therapy, I don't ask the patient to stop the treatment. And even in the center where I work in Canada, they didn't, my supervisor, he didn't used to do. However, the gynecologist or Dr. Ardalan, sometimes he would ask the patient to stop the Visicare. But it really depends what is the question. Do you want to diagnose the DOs, or you want to check the effectiveness of the anticholinergic on the patient?
Okay, Dr. Mohammed Babakri يسأل عن antibiotics. Did you give antibiotics?
So yes, we do give, but this is really depending on the protocols on each hospitals and each unit. So in our unit, we ask the patient to do urine culture, and only if it is clear, we will do the urodynamic. And after the urodynamic, we will give a prophylactic dose of whatever antibiotic you are using in the facility for 3 days. However, this is different. We know some colleagues from other centers worldwide, they don't even do a urine culture. They will just do urine RM. And if it is clear, they will just put the patient, do urodynamic, and send him home. So it really depends on the unit you are working in.
دكتور نبيل محي الدين بيسأل عن ال autonomic dysreflexia management and any way for prevention in suspected cases.
So we, of course, you have to have nifedipine all the time. We have it in our unit, and the filling should be very slow, and you should attach the patient to the Dynamap to record and observe the pressure of the patient, and you should pay attention if the patient on the first complaint of, or even you notice that he is upset, or he said, I'm starting to get headache, or I have a sweating or something, we have to abort immediately and empty the bladder, just give him nifedipine.
Again, دكتور إبراهيم النظاري أيضا دكتور طارق أحمد حاجب بيسألوا عن نفس الموضوع إنه vesico-ureteric reflux or large diverticulum, how to evaluate the pressure study, or أيضا السؤال بشكل آخر, how we read the result in patient with VUR.
It depends, as I said, it depends on the question why he is doing the urodynamic. So he wants to diagnose that this is a neurogenic bladder. He has to take all the information from the filling phase. Regarding the capacity, I don't think if he wants to know exact the anatomic capacity, maybe he will test the capacity under GA. But I mean, in the urodynamic, I don't put any patient an urodynamic test through this test unless he did a voiding diary, for which I know how much shall I expect we will go. And as I said, I know sometimes the voiding, the capacity, because of huge VUR, like the X-ray I put, and I could expect this is maybe 600 or 700. But if the functional capacity is only 300 and 400, if I push the patient and increase the fluid filled to the bladder, it will affect the results. So it's really custom made depending on the clinical condition of the patient and the question the urologist wants to answer.
دكتور إسماعيل المسلمي يسأل عن what's the age for a child with the posterior urethral valve to do urodynamic study?
Actually, we don't manage in our center, as you know, we don't manage the kids. So we are just a third party. Whenever there is one of our pediatricians requested urodynamic, we will do it for them. So I really don't know what are the protocols for this.
اوكي في احد الزملاء الاسم غير واضح ولكن هو حط as a case انه patient complaining of incontinence while urodynamic study is normal. What are the possible causes?
I'm sorry, can you say this again, please, Dr. Shukri?
He have patient complaining of incontinence
male
while urodynamic study is normal.
Male or female?
It is not clear, but
so okay. So let's take it in general.
If he can explain his question.
We did mention that the failure to reproduce the clinical complaint or the clinical symptoms of the patient does not rule out its existence. So he has to repeat it in a good way, or just do another test apart from the urodynamic. Sometimes, especially females with incontinence, they will be so alert about the incontinence. So when we do the Valsalva test, or we ask them to cough, they will contract their bladder, their sphincteric muscle, so there will be no incontinence. However, she will complain, I have stress incontinence 3-4 times per day. So as I said, failure to reproduce the symptom does not rule out its existence.
تقريبا نفس السؤال، يعني يدور حول نفس النقطة، والإجابة أعتقد أجبتي عليها، إنه دكتور مالك بيسأل إنه if the patient diagnosed clinically is going with overactive bladder, but urodynamic studies show no finding consistent with overactive bladder. Shall we prescribe anticholinergic for this patient?
It depends on the type of the incontinence. If it is a stress incontinence, so
no, overactive bladder, not speaking.
If it is overactive bladder, yes, he can. If there is no contraindication with the patient, Yeah, he can start with the overactive bladder, with the, I mean, anticholinergic.
I mean, he even the urodynamic studies not showing
yes.
overactive bladder.
There is no DOs, yes. Sometimes
Yeah.
actually the new guidelines, it's not new, I mean, for the last maybe 7-8 years, you can start anticholinergic if you are sure about the condition of the patient, urgency and urgent continence, without even requesting urodynamic. You can start with, and there is no contraindication, of course, from the patient side, you can start anticholinergic.
دكتور لطف الله غليث مرة ثانية يسأل عن avoiding diarrhea and history background. Is it necessary pre-test in all cases?
100%. I cannot emphasize the importance of the clinical history and the other tests like voiding diarrhea and uroflowmetry. Urodynamic, as I said, you have to have a certain question. If you just requested like a CBC or uroelectrolyte, it will not be of a benefit, and it will be just a bad experience for the patient because there was no definite questions and he doesn't know why you are requesting the urodynamic. So we cannot emphasize more the importance of the clinical history. Number one. Number two, examination, especially in case of female. Number three, uroflowmetry and voiding diarrhea.
في سؤال من الدكتور بشير بيسأل إنه does urodynamic mandatory done in incontinence? I think he means before treatment, but I don't know if he means surgical treatment of incontinence. Should be we do urodynamic?
So this is controversy through the whole world, and many factors play a role in these questions. Factors like the facility, the insurance of the patient, the health package in that country, will this support or no? But I'm talking about our unit. Usually, before I go for any surgical intervention, I would request for stress incontinence, I would request urodynamic. But in cases of redo, so if the patient came, and this is, I'm sure that there is no controversy worldwide. If the patient already did some surgical intervention to treat the stress urinary incontinence, it is wise to do urodynamic before you go again and do another surgery.
سؤال من الدكتور مالك. شكرا دكتور مالك، نشيط اليوم. فبيسأل if the patient doesn't reach the first sensation, how much should we continue the feeling phase?
So usually, let's put it in lay language. We ask the patient, the first sensation we translate it as when you feel that there is a urine, but you will not go to the toilet. You just know that there is a urine. So this is the first sensation. If the patient, sometimes they will not reach it, the accurate first sensation. It will be early because the presence of cystometric catheter in the urethra will give them a false sensation of desire to void. However, if the first sensation patient didn't reach it, however, he will reach a point that he will say, you know, I want to go to the toilet now. Then we will ask him, can you wait? Is this, if you are sitting at your house watching TV, will you go with this sensation? If he said yes, this means that this is the normal desire to void. If he said no, so this is the first sensation. Sometimes they will say, no, I will run to the bathroom, to the toilet. So this is the strong desire to void.
I think he means if the patient with neurogenic bladder and there is no sensation, no feeling, how much you will still feeling the bladder.
And is the patient, is there avoiding diarrhea? So he's voiding, or the patient is voiding at home?
No, during urodynamic study.
No, I mean, this is the important. This is the importance of the voiding diarrhea, Dr. Shukri. The voiding diarrhea, so we ask the patient to do it for 2 or 3 days, minimum 2 days. So when I see the patient is always voiding a volume between 600 and 700, 600 and 700. Okay, so maybe he has an autonomic, for example, autonomic neuropathy. He doesn't feel the bladder fullness, but I would expect that I will go until around 500, 600, 550, then he will start feeling.
ما زال لدينا دقيقة. اللي عاوز يسأل نستغل الفرصة. أي سؤال؟ في سؤال من الدكتور صادق يقول when I need to repeat urodynamic study.
When I need to it?
To repeat يعني urodynamic study. When you decide to repeat it يعني you are not satisfied with the study?
Usually, so there is a few conditions that you will need to repeat. I mean, without the surgical intervention, so just repeating it with no, he doesn't want to check the efficacy of the treatment or efficacy of surgery, just repeat due to artifact, for example.
Maybe he means that.
I understand the question.
Okay. عموما في سؤال آخر من الدكتور الأديمي. Is it mandatory pre-TURP?
So pre-TURP, it's if the patient is complaining of, for example, urgency and urgent incontinence, yes, because you want to document if he has first overactive bladder, number one. Number two, you want to make sure that after we remove the prostate through TURP, is the patient going to be able to empty himself, or he is already in the phase of decompensation. If he is in the phase of decompensation and you ask the patient to do the TUR, you instruct him, it's very important. In your mind, you are thinking about the upper tract. However, the patient thinks that after TUR, he will be shocked after TUR. He's not still completely emptying his bladder due to bladder decompensation. So prior to the TUR, urodynamic is important in counseling the patient, so the patient knows what to expect after the TURP.
حقيقة الوقت انتهى وما زال في أسئلة، لكن احنا ممكن نختم بسؤال الآن وبعدين نكملها في فترة الدسكشن الثانية إن شاء الله. دكتور نبيل المغلس يسأل عن البوزيشن. What's the better or best position? It is the supine or sitting position during urodynamic study?
So in pediatric, actually, we don't have a lot of options. It's pediatric less than 6 or around 7. So they will be supine. And of course, if they are anesthetized or sedated, younger pediatric group. However, in adults, it will be in supine position, in sitting position, especially the filling phase. The voiding phase, especially in males, they will say, I cannot void while sitting. I'm used to void while standing. Then we will stop the test. We will adjust the patient. We'll ask him to stand. We'll adjust the catheters. Then we will give him permission to void. But usually, most of the patients, sitting position is the best position.
شكرا جزيلا دكتورة هناء. حقيقة النقاش رائع وممتع، والزملاء بدأ النشاط يزداد أكثر الأسئلة، ولكن احنا عندنا الآن بريك لمدة 15 دقيقة عشان صلاة العشاء وأيضا يرتاحوا السبيكرز، ونعود إن شاء الله الساعة 7:15 دقيقة تماما. بالنسبة للأسئلة التي لم يرد عليها إن شاء الله في فترة النقاش الثانية ما زال لدينا 2 discussions sessions. في أمان الله. بسم الله الرحمن الرحيم. أتمنى تكونوا استمتعتوا بالبريك. الآن نرجع مرة أخرى وحنبدأ مع محاضرة الدكتورة هناء. في تغيير بسيط في البرنامج، كان في بعد محاضرة الدكتورة هناء ديسكشن وبعدين بريك، ففي فيدباك كثير جاء من الزملاء إنه تكون المحاضرتين ورا بعض، دكتورة هناء بعدين الدكتور أردلان، ويكون الديسكشن نستفيد من الوقت يكون في نهاية الويبينار. وأيضا في فترة بريك أعتقد أنه قد يعني بعض الزملاء قد لا يرى لها ضرورة، فإذا يعني نكون ديمقراطيين الذي يرى أنه لازم يكون في بريك ثاني بس يكتب في التعليقات نعم للبريك، أو أنه بإمكانه to cancel the break، وسنأخذ بآرائكم. الدكتورة هناء جاهزة؟
أي جاهزين إن شاء الله.
تفضلي دكتورة.
طيب. طيب، بسم الله الرحمن الرحيم. المحاضرة الثانية it's about abnormalities in urodynamic studies. So it's more practical and what do we read and how we read any abnormality in the urodynamic study. So we will talk about questions before urodynamic study. Then we will review quickly on certain terminology. Then we will see the urodynamic abnormalities in filling phase and urodynamic abnormalities during the voiding phase. So before urodynamic studies, these questions I would be happy if they were mine. However, they were framed by Paul Abrahams, which we call the father of the urodynamic. He had a long list of certain questions that the urologist should frame and phrase before he requests the urodynamic study. However, I think the three most important questions are: what do I want to know about this patient before I request the urodynamic? Is the urodynamics would be able to make a reliable diagnosis? And does the urodynamic studies reproduce the patient's complaint or no? So what do I want to know about this patient? Am I suspecting a dysfunction in the filling phase or in the voiding phase? Did I do surgery for him? And on follow-up, he said he still has this problem, for example, the incontinence. So I want to do urodynamic to check why there is a failure, and so on. So you have to know, the urologist has to have a certain wanted information that he wants to get from the urodynamic study. The second question is the urodynamics will be able to make a reliable diagnosis? So if I have a urodynamic unit in my facility, but I know that, for example, the urodynamic machine is old, or there is no good technicians or nurses to run this machine, so there will be a lot of artifacts, or I'm not the one who is running the urodynamic study myself, so maybe I don't know about the training of the one who is running the urodynamics itself. So there is no need for me, if I'm not sure that the urodynamic will give me a reliable diagnosis, there is no use from exposing the patient to this a bit of inconvenient study with no benefit. The third question: does the urodynamic studies, after I do, we do it, does the urodynamic studies reproduce the patient's complaint, and is it a must to have the complaint of the patient or no? So, for example, in cases of DOs, we know that even if the urodynamic did not show detrusor of activity, we can start the patient to on anticholinergic. However, in urodynamic stress incontinence, if everything is negative, the voiding diary, there was no stress incontinence registered by the patient in my cuff test to the patient, there was no urine leak. And during the urodynamic, there is no urine leak, so I would be a bit hesitant to operate on such patients. So these three questions are important before the urodynamic study. Certain terms, we've went through cystometrogram, the CMG, the EMG, the normal bladder sensation. As we mentioned, it's the 3-point during the filling phase, the first sensation, the first desire to void, which is the feeling leads to the patients to pass urine at the next convenient moment. However, the strong desire is the persistent desire to void without the fear, still without the fear of leakage. The abnormal bladder sensation, as we mentioned, it's either reduced sensation, absent sensation, non-specific bladder sensation, bladder pain, or urgency. This all you have to note it during the urodynamic study. The intravesical pressure, because we will say these terms repeatedly, so I'm emphasizing them. The intravesical is the pressure within the bladder. The abdominal pressure, which is P-ab, will be seen in the graph, is the pressure surrounding the bladder. It's either obtained through rectal or vaginal access. The detrusor pressure is the component of the intravesical pressure created by force on the bladder wall, and this is usually calculated automatically by the software. The detrusor overactivity is the involuntary detrusor contractions during the filling phase. As we mentioned, it's either spontaneous or provoked. That can be phasic, terminal, just before the voiding, neurogenic, or idiopathic. The urodynamic stress incontinence, it is the involuntary leakage of urine during increased abdominal pressure in the absence of detrusor contraction. This is important. Capacity, systometric capacity, it's the bladder volume at the end of the filling phase. As we mentioned before, this is the functional, not the true anatomical capacity. Maximum pressure during voiding is the maximum value of the measured pressure, and the pressure at maximum flow, or what we call P-det at Qmax, it's the lowest pressure recorded at the maximum measured flow rate of urine. So we will start with urodynamic abnormalities during the filling phase. Now we will read urodynamic abnormalities in the graph, then translated to clinical symptoms or terms. And another note that we will not discuss the urethral pressure profilometry for two reasons. It's not used very frequent in many centers worldwide. Number two, according to ICS, it's the data available when they did review the literatures did not support the significant role of urethral pressure profilometry in diagnosing or follow-up of the patients who are doing the urodynamic. So what abnormalities regarding the bladder sensation? It's either increased. This means that the patient will have the first sensation before we reach 100 ml of infusion. And now you can expect that the capacity will be less than 250. Or it will be reduced sensation when there is a later or delayed first sensation and normal desire to void. It can be absent. The patient void only by time, by the clock. He doesn't feel, and he will say, I don't feel the bladder, the bladder fullness before I go to peeing, so I'll just go every 4 hours, 6 hours, 8 hours. Urgency, it's a sudden compelling desire to void, and usually during the test, it will be a very sudden. The patient will be talking to you, then he will say, doctor, I need now to go to the toilet. And pain. When there is a pain, pain should be specified, the type and the site of the pain. Is usually in the urodynamic, the patient will have lower abdominal suprapubic pain, which signifies in frequent cases of interstitial cystitis. The second abnormality during the filling phase is the abnormal rise in detrusor pressure. We did mention this before. So the detrusor overactivity, this is very important. I know I said it before, but I really want to emphasize the DOs. If you can grasp the DOs, the difference between DOs and low compliance, this is a huge significance in diagnosing and the management of the patient. So we mentioned that it can be asymptomatic or associated with the urgency, the feeling of the patient, or associated with urine leak. And we sometimes care about the absolute value. So if the absolute value, so the the DOs was 6-8 centimeter water, and the patient is clinically symptomatic, he will have urgency and urgent incontinence or just frequency, we have to treat. But if the patient will have a value of 10 or 11 centimeter water and he's asymptomatic, no need for you to start any anticholinergic. So here is a graph. This is not from our center. So as we always say, just check the lines in the graph. So this is the vesicle pressure, P vesicle. This is the abdominal, and this is P det. We can see that there is a rise in P vesicle and P detrusor, and the abdominal is silent. This is a classic, typical DOs. This is another one also. You have to check the graphs, the lines. This is vesicle, P vesicle, P abdominal, and P detrusor. You can see here, there is a significant rise in the P vesicle and significant rise in the detrusor pressure. And here, just a minimal rise in the abdominal pressure. Maybe the patient is trying to contract his muscle so he will not leak. The low compliance, how the patient will feel during the test, he will have a desire to void, or there will be a urine leak before you reach the expected capacity. And we said that it can be due to neurogenic diseases or structural change that usually we see it after in radiation cystitis, after radiotherapy in radiation cystitis, or used to be seen when there is a TB cystitis. And also you have to document the DLPP as we mentioned in the first lecture. This is from Campbell. There is no color code. So what to do, just check the lines. This is the vesical pressure. This is the abdominal pressure, and this is the detrusor pressure. We can see that when there is low compliance, there will be a slow rise in both lines, vesical pressure and detrusor pressure, and there is no rise in the abdominal pressure. This is, again, a case of low compliance. You can see this is the vesical pressure, this is the detrusor pressure. You can see how the detrusor pressure is slowly rising. And here it's the same rising. However, here it's still the same. There is no rise. The third urodynamic abnormality during the filling phase is the urine leak. And urine leak can be in one of three conditions, either associated with DOs, which will signify urge urinary incontinence or translate the clinical picture of urge urinary incontinence, so you reach your diagnosis, or associated with Valsalva and cuff, which will diagnose a urodynamic stress incontinence, or it will be associated with constant rise in detrusor pressure, which will be translated clinically into overflow incontinence. Don't forget, whenever there is urine leak, you have to document the DLPP and the ALPP. The ALPP, we already mentioned it in the previous lecture. This is from our center, so vesical pressure, abdominal pressure, and detrusor pressure. Here, there is a rise in the vesical pressure and rise in the detrusor pressure. Abdominal pressure is silent, and this is during filling phase. This means that this is a DO. So you are trying, and this is the EMG. The patient is just trying to contract and prevent the leak. However, he cannot. You can see, I don't know if you can appreciate, there is this is the flow. There is one small rise here, and there is one small rise here. This signifies the leak. So the patient is leaking just a few drops, not significant for a flow, but definitely recorded in the machine. And this is also from our center. This is the vesical pressure, abdominal pressure and detrusor pressure. So usually we ask the patient to cuff or do Valsalva. Cuff, just a sudden strong cuff. Valsalva, we ask the patient to take a deep breath, hold the breath and start pushing down. And you can see the leak here. We sometimes if we are attending and we can mark it with LE. If you can see it, this means leak. And you can see also in the flow this small increase in the amplitude of the flow curve, which means that there is a few drops reach to the flask. This is another graph, not from our center. We check, this is the vesical pressure, this is the abdominal pressure. So there is a rise in both vesical pressure and abdominal pressure. This means that the patient is doing Valsalva or cuff, which I think here it's a Valsalva, and there is a leak, and there is no significant contraction in the detrusor pressure. This is from our center. You can see there is a slow rise in the vesical pressure and the detrusor pressure. Slow rise. However, the abdominal pressure is still, still silent. There is no rise. And you can see here, this is the flow. And here started the patient to leak few drops. I think you can appreciate this better than the previous graphs, because with leak, she couldn't hold her urine with rise in the detrusor pressure. So the DLPP will be immediately here. When started, we mark this point here on the detrusor pressure, and we calculate it because this is where the urine leak started. So now we finished the urodynamic abnormalities during the filling phase. We talked about abnormal bladder sensation. We talked about abnormal rise in detrusor pressure and the urine leak. Now, the urodynamic abnormalities during the voiding phase, which is mainly the detrusor contractility. We did say in the last culture that normal detrusor activity, we marked it when the detrusor muscle contracts to empty the bladder within a normal flow rate and with normal flow rate and within normal time span. When it is increased, this means that there is an outlet obstruction. So the detrusor muscle is trying to overcome this outlet obstruction. When there is underactivity, this means that the contraction of reduced strength and or duration, leading to failure to completely empty the bladder within a normal time span. Detrusor acontractility, the bladder has no demonstrable contraction during the voiding phase. So there are two important parameters. I know I've talked about them, but we have to talk about them again. The first one is the maximum pressure, or we call PDET max, or the peak pressure. And this is a picture from the software. So the software under the title of voiding summary will mention to you what was the peak pressure. So in this patient, the peak pressure was 27.4. So it is a maximum value, the maximum value of the measured pressure during voiding, which is, or we sometimes you call it the peak amplitude of the voiding pressure curve. The second one is the pressure at maximum flow, or pressure at peak flow, what we abbreviated by PDET at Qmax. It's also calculated automatically by the software, pressure at peak flow. Here, the pressure at peak flow was 24.2 centimeter water, and it's usually the detrusor pressure recorded at the maximum flow rate while the patient was voiding. So why it is important? Because it helps you in calculating the bladder outlet obstruction index and the bladder contractility index. This is calculated automatically. However, we know that we can calculate it in case of artifact, we can do it manually, and we can calculate it. The normal detrusor activity while voiding, there is no an absolute normal value, but we do know that the maximum PDET should be less than 40 centimeter water. And a BO index and bladder contractility index will help us to assess the function of detrusor muscles more than the absolute value of the pressure itself. When there is increased detrusor activity, we will suspect outlet resistance. For example, anatomically, like prosthetic enlargement in male, or pelvic prolapse in female, or there is a functional obstruction like cases of sphincteric dyssynergia. However, in cases of decreased detrusor activity, or sometimes even acontractility, we expected most of the time in cases of neurogenic bladder, or in cases of decompensated bladder, usually after long, prolonged anatomical obstruction. So to know, this is the normal detrusor pressure. This is the screen we have in our machine. So this is a bit of artifact, this zigzag, which means that the patient was talking maybe, but still there is no significant. This is, we ask the patient to cough. When we ask the patient to cough, just to check the functions of the catheters, then we give the patient permission here. PE, I don't know if you can see PE, permission to void. So we will go outside the room. The patient, there is a rise, normal rise of the detrusor pressure. This is the flow recorded, and there is no significant straining in vesical and abdominal, within abdominal muscle. This is an example of increased detrusor pressure. So here, the vesical pressure, this is the abdominal pressure, and this is the detrusor pressure. And you can see how the detrusor pressure increased significantly. It reached 67. You know, those each line signifies 10 centimeter water. So it reached 67 while voiding. However, the urine flow is maximum 8 ml per second. So this is increased detrusor obstruction. And we know this patient has prostate enlargement. This is another graph from another center. We have to check the line. This is P vesical, this is P abdominal, and this is detrusor pressure. And here is the flow, ml per second. So we can see there is a rise in the vesical pressure. There is a significant rise also in the detrusor pressure. Abdominal, there is no significant rise, and there is no urine flow initially. It took a long time. Then the patient tried again. And you can see here, this is, each line is 50. So this is 50, this is 100. So the patient is voiding with detrusor pressure close to 130 or 140, which is significant increase in the detrusor pressure. Now the detrusor underactivity. So here, the vesical pressure, abdominal pressure, and detrusor pressure. You can see the patient with his abdominal muscle is trying, he's straining to empty the bladder. He's training to initiate what we said, the normally voluntarily initiated rise in detrusor pressure. He's trying, and we can see the rise in detrusor pressure only while straining. However, you can see here in this point, if there is no straining, it's maybe 10 or 11. So whenever there is a rise in the abdomen, there will be a rise in vesical pressure and a small rise on the detrusor pressure. Then the detrusor pressure again back to 4 or 3 centimeter water. So this is an example of detrusor underactivity. This is an example of detrusor acontractility. You can say, so this is the vesical, this is the abdominal, and this is the detrusor. You can see the difference here. Even with this straining, the patient is straining, and here he's coughing, trying to empty, trying to generate a rise in detrusor pressure, but there is no significant rise, even with detrusor, even with the straining, and this is a contractile detrusor muscle. This is another example of detrusor acontractility. This is the vesical pressure, this is the abdominal pressure, and this is the detrusor pressure. We can see here, stop infusion. After they stop the infusion, they give the patient the permission to void. He's trying. So we can see the rise in vesical pressure and abdominal pressure. However, detrusor pressure, there was no significant rise. And that concludes our second presentation.
شكرا جزيلا دكتورة هناء. طبعا احنا عملنا سيرفي على البريك if we need a second break، فكانت الريزلت no there is no need for a second break، ولهذا احنا نتبع رأي الجمهور والأغلبية، وحيكون البرنامج إن الدكتور أردلان الآن يبدأ بالمحاضرة، بعدها حيكون نستغل باقي الوقت في الدسكشن. دكتور أردلان يتفضل. محاضرة الدكتور أردلان حتكون عن basic Urodynamic courses وفي interested case scenarios إن شاء الله تستفيدوا منها. دكتور أردلان open your
السلام عليكم ورحمة الله. Can you hear me?
Yes تفضل. وعليكم السلام ورحمة الله.
السلام عليكم. بسم الله الرحمن الرحيم. It's my pleasure to be with our colleague, and thanks to everyone who made this meeting successful. I will not go further just because we are running out of time. I would like to just mention a few, before I start my case scenarios, just few points about in general, about urodynamics and what we are getting in our section. So as Dr. Hanaa, she very well, she elaborated on urodynamics. She covered everything, mashallah. She didn't let anything for me to discuss about the urodynamic reproducibility. So do not think that the urodynamic test, it's a magic. According to the literature, around 75% or maximum 80% of the cases are reproducible. Sometimes it is not reproducible. And in very rare cases, as Dr. Hanaa also said, that you have to repeat it. This is one. And the second point is also a thing, where will you find the problem, if it is in filling phase or in voiding phase, or sometime in both. One advice I always give it to my residents and fellows: please do not treat the urodynamic traces. You are a clinician, you are a doctor. Take this as patient as a whole. So make only urodynamic as a enhancing test to help you in getting to diagnosis and treatment. Video urodynamic, it's extremely important, especially in children. Unfortunately, I've seen places in which, pediatric hospitals in which they are doing urodynamic for the children and they are not having an X-ray. These kind of urodynamic reports are incomplete in my opinion, and it's extremely important in neurourology or pediatric cases, most of the pediatric cases. One more point is doing urodynamic while the patient is having UTIs, so infection. Well, many of or most of the patients who are on clean intermittent catheterization because of acontractile or undercontractile detrusor, let's say spinal cord injured patient, for sure they have what we say is asymptomatic bacteria, and this is not active infection. But those who are having really acute infection with symptoms of UTI, I do not recommend to do urodynamic, sometimes even with antibiotic coverage, because many of the time the true overactivity happens in the urodynamic. You cannot even complete their test. Last word about autonomic dysreflexia. It's a very important issue. I think some of the colleagues, they asked about it, and Dr. Hanaa also, she answered well. I just want to add a small point that this usually happened usually happen in the cervical spinal cord injuries, or there is any disease in the cervical area. And you should be really alert. You have to monitor from the beginning the patient's blood pressure, because in a seconds, the blood pressure can go from, let's say, 120 to 200, 240. If he has a small aneurysm in his brain, it will just burst. So it is dangerous. Keep your NEFIDP, as Dr. Hanaa said, ready, and always try to empty the bladder immediately, and make sure that the patient rectum is not lodged with feces, because this is another reason for autonomic dysreflexia. Okay, so we have 6 cases. I'll try to go very fast. Most of the traces already Dr. Hanaa showed it to you about the abnormalities. These are the cases in our daily practice. Daily practice cases. I did not bring it from anywhere. So maybe you will find some detailed informations are missing. I just copied what we are doing every day in our clinic. So I have no actual or potential conflict of interest in relation to this presentation. Case 1. So this is a 44-year-old lady complaining of mixed urinary incontinence, meaning that she's having urge urinary incontinence plus stress urinary incontinence, saying that I cannot reach the toilet, I have to run very fast, and sometimes on coughing, laughing, sneezing, lifting heavy object, I leak. She does not have any other lower urinary tract symptoms. She has normal bowel habits, no dyspareunia or no dysuria. Married with 3 pregnancies, and all are normal vaginal deliveries. None of the babies were above 4 kgs, because if the literature showed that if the babies are above 4 kilograms during the normal delivery, this can impact on the pelvic floor muscles, and she can develop a stress urinary incontinence. So she was given an anticholinergics for urge urinary incontinence, like Vesicare, Ditrozitol, Distropan, and she had a good response, but still she was complaining of a stress urinary incontinence. Her past medical history, she has vitamin D deficiency and no history of surgeries. Genital examination, she had urethrocoel, grade 2 cystocele, meaning anterior descent, and grade 1 rectocele, which is posterior descent. But as I mentioned, she had normal bowel habits, so she did not have to strain herself, even not having constipation to pass stool. Renal function test was normal, urine cultures were normal, ultrasound, kidneys were normal, bladder was normal in outline and capacity, showing that full bladder was 513 and post-void residual urine was 70 ml. 513 meaning that she could hold a good amount of urine. Uroflowmetry was done, and void, it's an international continence society abbreviation for uroflowmetry. The first number is 18, and the lower one I just copied it, it's wrong. We should not put any 0.4, 0.2, point this. We always have to round it to a number, so 18. Then she voided, so 18 ml per second. She voided 353, and her post-void residual urine was 60. Pattern of this uroflowmetry was bell-shaped. I don't have the uroflowmetry of this patient, unfortunately, to show to you. Her second uroflowmetry showed 15, and she, I think this was wrong, 136 she voided, and the residual one was 22. Pattern bell-shaped. A pad test, 1 hour pad test was negative, so it was below 2 grams. Regarding the pad test, there are 2 schools. Some they do 24 hours pad test, so they give pads to the patient, they go home and they just wait it and bring it back. Most of the places they do 1 hour pad test, and I think it can give us a good information about the leakage. So this is a urodynamic. This is a filling phase of the urodynamic. First thing, when we start the urodynamic, we have to see the pressures. So the pressure P-det, which is the detrusor pressure, usually it should be -5 to +5. It doesn't matter. It's never zero. Nothing in urodynamic is zero. Abdomen and vesicle, depending on what is the position of the patient, if she is sleeping, standing, sitting, there is always pressure inside the abdomen, as Dr. Hanaa also mentioned to you. And always I used to tell my resident that P-ves, which is P-vesicle, it's a mirror of P-abdomen and P-detrusor. So any rise in P-abdomen and P-detrusor, you will find this rise mirrored in P-vesicle, okay? So here we can see that there is a pressure inside the abdomen, which is good. And the same thing we can see it in P-vesicle. Then she's coughing here, and the coughing is similar. So we say that this urodynamic is traces is good and well calibrated, and transmission of the coughing is going well to the computer or the urodynamic machine. Okay, so we fill the bladder, and we see in the meantime that here there is a rise in the abdominal, small rise in abdominal pressure, and there is an incline, or I can say this pressure is coming down to the minus of the detrusor. So when you see this one, this is not any abnormalities. In this case, the patient is squeezing herself from down, maybe trying to hold herself. We call it rectal contraction or sphincteric contraction. So here the patient is doing Valsalva, okay, and there is, it's not obvious here. We always make our nurse to look at the urethra when the patient is doing Valsalva, and we see if there is leak. So there was a leak here, and this is called urodynamic stress urinary incontinence. And then after that, she coughed also, and she leaked during the cough after that. So this is Valsalva, and this is cough. And why we do Valsalva? Why we don't say that, okay, if patient is usually, they come saying, doctor, when I'm coughing, I'm leaking. So why we always do, why they say that we have to do Valsalva? Because Valsalva, it's increased intra-abdominal pressure in which it can be measurable. Cough, it is so fast that the computer system cannot measure it. That's why we have to do both to see if the patient is leaking or not. Then this is the pressure flow study. So here we see that we infuse the patient with 420 ml of saline, and she voided 442. So she voided to complete. And we have to check after she finishes her urination, which is this one, this is the flow. And she had not bad, 28 reached the detrusor pressure, which is normal for a ladies. And we have to check, we have to tell the patient to cough at the end of urodynamic just to see if all traces are in place. So because sometimes when the patient is voiding the systometric catheter, which is only 7 Sharir can come out. So can give us a wrong information. So this is the whole test with CMG, which is the cystometrogram, and pressure flow study, PFS. So I just wrote this for somebody who is recording this lecture. So our report is in this position. I mean, it looks like this. If somebody wants to just copy it for their report, it's a good one. So first sensation was felt at 42, normal at 322, strong, capacity 400. All these sensations, I think it was somehow normal. Although the first sensation usually starts at 60, but we can consider it somehow okay. Compliance was normal. There was no any rise in the detrusor pressure during the filling phase. There were no evidences of uninhibited detrusor overactivity. So no detrusor overactivity. On several occasions during cystometry, she did leak with cough and Valsalva, as we saw. So we measure the ALPP, abdominal leak point pressure, or sometimes it's called Valsalva leak point pressure. It was more than 100 centimeter water. Now, pressure flow study, she voided the whole thing with no PVR. Qmax was 9. Usually, we have to check her pre-urodynamic test uroflowmetries, because that she's passing urine in the toilet, and usually it's higher than this. So maybe this low Qmax could have been because of systometric catheter. Well, many studies showed, many older studies, they showed that usually catheter with 6 French and lower will not alter the pressure flow study, but there are some newer research is showing that it does sometimes. So that's why you have to do sometimes until 3 uroflowmetries for the patient before the test, just to compare it between pressure flow study and uroflowmetry. Okay, so prophylactic antibiotic was given. So impression was like normal sensation, compliance, bladder capacity was 420, a stable detrusor, and urodynamic stress in urinary incontinence. Pressure flow study, it was unobstructed study with fair detrusor tone and complete emptying. So we advise the patient to repeat the uroflowmetry because she had the complaint of sense of incomplete emptying, and then to book her for transobturator vaginal sling operation, plus minus anterior repair, cystocele repair. So after that, she did 2-3 uroflowmetries, and it showed that she's not emptying herself completely. So she is for TOT and anterior repair, I think, next month, inshallah. Okay, so this was a simple urodynamic. I elaborated more on urodynamic traces because this meeting is actually focused on urodynamic. Let's go to the next one. So this is a 55-year-old gentleman. You can write any questions you want now to Dr. Shukri, and just write case 1, case 2, case 3. So if you want, we can refer it easier later to the cases. So this is 55-year-old gentleman complaining of voiding glands for more than 1.5 years, which did not improve on any alpha blocker. He has weak interrupted stream, nocturia 1 to 2 times. He has no sense of incomplete emptying, so he feels that he empties completely. He has frequency, urgency. He had once gross hematuria, constipation, or dysuria. I think this gross hematuria, he was checked and it was fine with scopy with another team. Married with kids, and he had good erection. No back pain. He had diabetes. He's diabetic for 5 years, well controlled. No surgical history, no allergy. He's on aspirin. Renal function test is normal. Urine culture is normal. PSA is 3.9. It's normal. Examination showed soft abdomen, soft, lax, non-tender, and no organomegaly. He is non-circumcised. He has left epididymal cyst. Otherwise, normal genital and non-tender. Digital examination, non-tender, a small size, benign feeling prostate. Ultrasound, kidneys were normal, the bladder shape, outline normal, normal wall thickness. And this is important, I think, regarding the wall thickness. Many radiologists, the normal bladder wall thickness is usually 4 milli. And usually they don't measure it well because they, let's say, fill the bladder until 150, and then they measure the bladder thickness and they say it's thickened, or they fill the bladder, let's say, with 500-600 ml of water or urine, and then they say is that the whole bladder is thin. So always correlate between the bladder wall thickness and how much was inside the bladder, which is, I think, here is normal. And he had post-void residual urine of 79. Prostate size was small, as you can see, 19. Uroflowmetry here shows that Qmax is 8 in both uroflowmetries. He passed 271, 281, and residual urine was high, 291, 220 is almost more than sometimes half. He's only emptying. I mean, and the flow showed interrupted flow. So bladder diary, maximum voided volume 510. Usually this is happening in the morning time. Average voided volume was 250. Frequency of urination 10. Nocturia, no. Nocturnal polyuria, no. And he had no leak. This is his uroflowmetry, as we mentioned it, just the traces. This is 2 uroflowmetries he had. We did for him IPSS, and it showed that IPSS storage symptoms was 22, and quality of life it was 5. So it was not good. This is the bladder diary we are having in our institute. So he wrote, and I already mentioned it to you. I just put it to see how it is. And if any of you want this one, we can send it to you. Okay, so this is the uroflowmetry of this patient. Again, from beginning, we check the traces if the transmission is good. And here we see it's good. The Truser pressure is on almost 0. And there is abdominal pressure, and you can see the reflection of abdominal pressure in the vesical pressure. So everything is good. He's coughing, very good. This one is called biphasic substruction. It's something related to the computer, transmission of the pressure through the systematic catheter to the computer. So this is not artifact. Okay, so everything is going good, and then as this one I mentioned, he's not doing abdominal straining, and this is the pressure follow study. So, and this is a CMG plus pressure follow study, and here we can see I made it bigger. The pressure follow study, we can see that this patient is having high pressure and low flow. He is having high pressure and low flow. So this is important to know the abnormalities, as Dr. Hanaa also said in the pressure follow study, because if we have high pressure like this one and low flow, so this is an obstructive case. If we have low pressure and low flow, it can be underactive detrusor. If the pressure is low and the flow is high, the pressure is low and flow is high, that's usually the normal people. And if the pressure is high and flow is high, what that can be? Just think. Well, that does not exist, okay? So this is important. And plus that some studies, they showed that 1/3 of the people who are having, let's say, obstruction because of infravesical obstruction, they have also detrusor overactivity. Once you remove it, this urgency what the patient is having also it is gone. Okay, so this is high pressure, low flow, infused volume, and voided volume. So we put him 400 and he voided only 140. So as Dr. Hanaa also said, this is called BOO index, bladder outlet obstruction index, in which we calculated as pressure, highest pressure, detrusor pressure at highest flow minus 2 multiplied by highest flow. This is what our urodynamic system generates. As you can see, the systemetry, we take it usually from here. First desire, first sensation, first desire, strong desire, capacity. Then we go to the pressure flow study. We can see that pressure at peak flow is 92. It's very high. And bladder contractility index is 87. So as we mentioned, if it is below 20, the patient is unobstructed. If he is above 40, he's obstructed. If it is between 2, it's equivocal study. And accordingly, you have to judge. And many patients we get from the general teams in which the pressure follow study comes up with equivocal study. So you don't know if he is really obstructed or unobstructed. Then really you have to go and judge clinically. Very important. Again, I emphasize on this point, do not treat the traces or do not treat the urodynamic, treat the patient as a whole. Okay, so bladder contractility index is also written here, in which not all the urologists worldwide, they take it into account, this one, but it shows that if it is above 100, that meaning that the patient's detrusor muscle has good strength. And if it is below 60, well, that indicates that he has underactive detrusor. Post-void residual urine was 257. Okay, so again, I will not go again through all this. So we mentioned it, we talked about it. And here, as we see, Dr. Hanaa already mentioned this one. I also mentioned it. So here, what is your plan? What would you do for this patient? Case 2, okay? So this was case 2. Let me know later. Case 3. This is 45-year-old lady who is complaining of frequency, urgency, and urge incontinence more than 10 times per day. She's also complaining of stress-free incontinence with laugh, cough, lifting heavy object, and changing in positions. She is bothered by both the incontinence, because this is very important. Always you have to ask the patient which one is bothering her more. She has nocturia up to 3 times per night, every night, using pads, a thick one, change 3 times per day, always socks. So she is, I think, the quality of life, she's having miserable quality of life. So no obstructive lats, no dysuria, no hematuria, no constipation or defecation, or defecation difficulty. Allergic to penicillin, not an anticoagulant, menstrual cycle is irregular, already on follow-up with gynae. Pregnancy, she's not married, although she's 45, she was not married. Investigation, renal function test was normal, urine culture is negative, no medical history. She had intravesical Botox injection in 2015. Gynecological disease, no, and she had an improvement on that injection. Kidneys are fine on ultrasound, bladder is okay, but here the radiologist was stated that patient is unable to hold more. So full bladder measured only 131 and she emptied herself completely. So uroflowmetry shows that her flow is very good, 33. Bladder capacity is lower than usual and she's emptying, and the pattern is urgency pattern of the flow. And the second one is almost the same. She had 60 ml post-void resolution, which is fine. Pad test was positive, not very. She is saying, so there is here little controversy. She's saying the whole thick pad is soaked. And when we did the pad test, it was only 3 grams. So below 2 grams is negative. So it was not strongly positive. Max bladder diary showed voided volume, maximum volume of 100, frequency 10 times, average less than 50, showing severe urgency, and frequency nocturia twice, no nocturia, and leaks. She has written that she really leaks with cough and sneezing. So this is the cystometry, the filling phase of the patient. Again, I don't want to mention, she had leak there. So she, as you can see, that there is a rise in the detrusor pressure. This is somehow silent abdomen, and this rise is showing here in the vesical pressure. So again, she had here leak, and this time she coughed, and also you can see mirrored here in the vesical pressure. So she had leak with urgency and with stress. So this is very obvious. You can see that this is mirrored here and this is mirrored here, right? So this is a case of mixed urinary incontinence. And then this is the pressure follow study. And pressure follow study, you can see, as I mentioned in previous case, we told her that please cough at the end of the study, and it was not the right one. So here, maybe the systometric catheter slipped out. So until this part, everything was fine. As you can see, the patient is maybe coughing or doing something, so the transmission is good. But here, I think it slipped out at the end of the urodynamic. Okay, but our test was fine. I mean, there was no problem with it. Okay, so let's go on. I don't want to go into detail about this. So here we saw that this nomogram, it showed that she is unobstructed on pressure follow study. So if you see that sensation in her is premature, she has premature sensation. Capacity, she has low functional bladder capacity, is not high. compliance is normal in her. There were evidences of detrusor overactivity as we saw, but the detrusor pressure reached only 18, which is not very high, but it is high. Anyway, she is bothered with this. And she had urodynamic distress incontinence, and abdominal leak point pressure is showing around 90. One thing, just a reminder that detrusor, when we talk about, let's talk about this later, about DLPP and LALPP, because this is a common thing, people make mistake about it. The detrusor leak point pressure, which is a very important component of low compliance, it is measured by detrusor pressure. Abdominal leak point pressure is a component of stress during incontinence or incompetent sphincter. It's measured by vesical pressure and not by abdominal pressure. This is a very common mistake, especially for residents who are going for the exam. Okay, so also patient leaked several times with cough. Pressure flow study, again here it was 9. See, you can see that she voted 130, it was 9, it was low, but we can see that she's having a normal flowmetry, so we can disregard this. Okay, so totally she emptied herself and peak pressure was 21. So again, in summary, impression, premature sensation with a small bladder capacity, functional capacity, detrusor overactivity, Valsalva-induced detrusor pressure, urodynamic stress and incontinence. On pressure flow study, this was unobstructed study with fair detrusor tone and complete emptying. You have to mention these 3 things in the pressure flow study. Okay, so if it is obstructed or not, how is the detrusor muscle tone, and if she empties or not. Okay, so again here, what is your plan? This is very tricky, these kind of patients. What would you do? They are having both. They have stress urinary incontinence and they have urge urinary incontinence. So what is your plan in these patients? We are mainly talking about the truth about urodynamic traces. Okay, so we are not talking about how to treat this patient, but I leave this for you to judge it, and I'm ready to answer at the end of this presentation. Okay, because maybe some of you are saying why the doctor is not writing the solution. Case 4, this is shorter. This is 24-year-old male patient on wheelchair due to lower limb weakness and deformity. He is a known case of meningomyelocele, which was operated in his childhood. He is on diaper, wet all the time, and being changed every 2 hours. He has double incontinence, meaning incontinence of urine and stool. He is on suppressive antibiotic, prophylactic antibiotics, cephalexin, which was given by infectious disease team in our hospital. He has no history of recurrent symptomatic UTIs. He is not on clean intermittent catheterization, and he avoids by straining most of the time, okay, using abdominal muscle. So he has chronic constipation and he is on phosphate enema, and he's doing well with that. Serum creatinine is normal, 62. Urine culture at the time of urodynamic shows no growth. Ultrasound, kidneys appear normal, no stones, no hydronephrosis. Urinary bladder is smooth and it holds the urine of 2 to 6, and post-void residual urine is only 16. So until here, everything looks nice. A normal kidney function. Ultrasound looks somehow fine. Urine culture is okay. He is on prophylactic antibiotic. Bowel, he's doing very well on phosphate enema, although we know that he is kind of MMC, which is meningomyelocele. So, I mean, usually we expect problem in this patient, but he's fine. But when we did urodynamic, see what we found out. So this is a cystometry. So in cystometry, I think I don't want to repeat it, even because of the time. Everything is fine. He's coughing, transmission, everything is good, except that you can see there is a steady increase in detrusor pressure which indicate that this bladder is little of low compliance. So compliance is low in this patient. And usually if you want to know that if really this is low compliance or his bladder is sensitive, it's because the detrusor rising, you can stop the filling the bladder. And if this detrusor comes down to normal, then this is not case of low compliance bladder. But in his case, no, it is low compliance. So filling phase, in this case, show low compliance bladder. Now see the voiding phase. I think Dr. Hanaa also showed a slide like this. He is totally straining. You can see he's straining by his abdominal muscle to pass urine. This rise, and you can see that his flow is interrupted flow. He is empty, but interrupted flow. And there is somehow a small rise in the detrusor pressure, which is, I think, not very significant. So mainly, he is passing urine, he's emptying himself with straining, which indicates that his detrusor is not working because of meningomyelocele. Okay, so this is the urodynamic as a whole. Okay, so this is case of underactive detrusor. This is a video urodynamic in which we did. Maybe some of you will ask why he has bladder like this going to the side, and this because of the deformity. So in CMG, we can see that impaired sensation. He doesn't have sensation. Capacity reached 450. Compliance was normal. It was not normal. Sorry, this is a mistake I've written. Compliance is reduced. Okay, sorry for that. There were no evidence of uninhibited detrusor contraction. On several occasions during cystometry, he did not leak with cough and valsalva. So it was competent, his sphincter. Okay, so he did not have detrusor overactivity, but his compliance was reduced and not normal. Now, the patient on pressure flow study voided a volume of 346. Totally straining and interrupted flow. The detrusor was underactive, and the rise in pressure flow study is associated with abdominal straining, which is not significant. Post-void residual urine is 100, and video shows a smooth bladder outline, closed bladder neck, no reflux, and no filling defect. Continue on prophylactic antibiotic. In this patient, what is your plan? So he has neurogenic bladder, as we see that underactive bladder, and with low compliance. What is your treatment? What do you plan for this patient? I didn't want to show that. Anyway, we did a cystoscopy for him and it was normal. Okay, so because of this bladder shape, also there was some deviation inside the urethra, which was not significant. So you can say it was normal. Case 5. 30 years old male, this is an interesting case. 30 years old male, known case of a spinal cord injury, T12 to L1, has neurological blood. He has neurological bladder on clean intermittent catheterization 6 times per day, and he's using diaper. He leaks between catheterization, with changing diaper being wet most of the time. He has no dysuria or hematuria. The patient has erectile dysfunction. He's not married. He underwent intravesical Botox injection in 2017 and 18 with 200 international unit of Botox, botulinum toxin A. He has no recurrent UTIs, not married, but he's under investigation with our infertility team, which are doing very well with him. He has his other medical history is negative, none. Ultrasound shows bilateral mild hydronephrotic changes. A small capacity urinary bladder showing thickened trabeculated wall. Renal function test is normal, and his urine culture, he has Klebsiella pneumoniae and on trimethoprim sulfamethoxazole as a treatment for him. It was as a treatment. So this is a cystometry. Again, it's the beginning is good. This is good. The traces are well transmitted, and you can see again the same thing. 2 things you can see here, that the detrusor is steadily going up. So he has low compliance bladder. When we asked him to cough, he leaked. That's why I put cuff, leak point pressure. It's only, there is no any measurement for this, just he leaks, so somehow incompetent sphincter. And he, when infusing, the detrusor was going up and up and up until he leaked. So this is a detrusor leak point pressure, in which, again, I say we measure it by detrusor pressure. Abdominal leak point pressure, for stress, we measure it by vesical pressure. Okay. So CMG sensation was not felt, so it is there is no sensation. Capacity reached around 300. Compliance was low. DLPP 44 centimeter water. Very important to know this. I'm going to mention it. And there were no evidence of uninhibited detrusor contraction. Stable detrusor. The patient voided the volume of 133 by straining because he has underactive bladder, similar to the previous case. Now, in this one video, it showed irregular bladder outline, open bladder neck, no reflux, and no filling defect. And this graph shows that this patient is having detrusor leak point pressure above 40 centimeter water, which is called Maguire leak point pressure. Dr. Maguire, I think he's living in US. He found out that when the pressure inside the bladder reaches 40 centimeter water, there is no any urine comes out from the bladder, from the kidney to the bladder. Now, if it goes above 40, then urine will go up. And if it goes higher and higher, by time, it will go up and up, and it will damage the kidney by the time. So a detrusor leak point pressure above 40 is an absolute indication for a treatment. What kind of treatment? There are so many types of treatment. Okay, so this was his X-ray, and we can see trismus tree neurogenic bladder with open bladder neck. What is your plan for this? This one, I will not wait for you to think. I'm going to tell you what we did for him. I think it was last year. We did augmentation ileocystoplasty with umbilical catheterizable stoma, and he's doing very well. He's a young guy, very active, and he's doing well. And thanks God, he's not also leaking from downwards, although he had incompetent sphincter, because there are some cases in which we close the bladder neck. But especially in young patient like him, not married, he doesn't have any other diseases. If we close the bladder neck, he might have something called dry urethra syndrome. And again, it might affect also his infertility and andrology problems. So he's fine, walillah alhamd. Case 6, last one. This is very short. It is not complete test, but I put it for a reason. So this is 20 years old male with a history of spina bifida, again with bilateral lower limb paralysis, loss of sensation with loss of bladder and bowel control, so double incontinence, okay? On X-ray, the patient had lumbar kyphoscoliosis, absence of laminae in the lumbar spine. MRI showed lumbar spine spina bifida, operated in childhood, syringomyalgia, atrophy of paraspinal muscles. Anyway, he was not on follow-up with the urology, not even with us. So he came, 20 years old, he just came for the first time to us. He was doing CIC 4 to 5 times per day with leak between CIC. And he was on detrositol 4 milligram as an anticholinergic or antimuscarinic. So from outside, maybe outside Qatar or in private, this treatment he was giving to him, so CIC plus anticholinergics. He had nocturnal enuresis, no hematuria. He had UTI recently and received antibiotic, in which he had improvement. Mostly he had normal bowel habit. He had erectile dysfunction. He was not married. Now, this one, let's see his urodynamic. It's very, very interesting. So impression and ultrasound, neurogenic urinary bladder with bilateral hydronephrosis worse on the right side. So this is what we found out in his urodynamic. We did a renogram with technetium 99, MAC3, Lasix given, renal scintigraphy, which showed impression moderate to severe right hydronephrosis and hydroureter, severely reduced function, therefore obstruction cannot be ruled out. Unremarkable left kidney. So function of the right kidney was 8% and left kidney was 92%. And this is our urodynamic. You can see that he didn't have any sensation. 273 ml was infused, but he had, you can see here, it's going up again. He had low compliance. So you see that from here, it's good. Well, we put for him 273, low compliance, which is good. Maybe anticoagulants can be given to him, or some other maybe intravesical Botox injection can be given to him. He will be fine. But when we did a video urodynamic with X-ray, we found that he is having this. He is having grade 5 vesico-ureteric reflex on the right side. So and his DLPP again, also this was high. So my message from this one, this case, is that sometimes video urodynamic is crucial. So his real bladder capacity, it's much lower than what was infused, 270, because this is called a pop-off phenomenon. Pop-off phenomenon in which when the contrast or this one, it goes to the upper tract and you cannot rely on it. You cannot see exactly, you cannot estimate his pressure or his volume inside the bladder. Anyway, also let me know what is your plan about this patient. Thank you. We talked a lot. We can have a good discussion now. So this is our team from urology, excellent team, and thanks to everybody for all their support.
Thank you, Dr. Ardalan. شكرا جزيلا for this interested cases. صراحة interested and selected to be informative. الآن ممكن نبدأ بالدسكشن. لدينا تقريبا نصف ساعة من الآن. وحنشوف الأسئلة اللي رجاء اللي بيسأل على كيس معين أو discussion about one of these cases, just to mention the case number so we can يعني to be oriented. كمان نتمنى تفاعل أكثر من الفيميل يورولوجيست in Yemen. We have دكتورة أروى السلامي موجودة معنا، دكتورة عائشة خيران. I don't know if she is here, but we are proud to have female urologists in Yemen. We can start the questions. ترتيب دكتور. Okay. So Dr. Malik Ahmed, he has question: how much should be the urodynamic study chair high in relation to the urodynamic machine? He means the calibration, I think, his question. دكتورة هناء معنا؟ Okay, Dr. Ardalan.
Sorry, tell me again
the question. He is asking a technical question about the relation between the highest or of the chair and the urodynamic machine. I think he means the calibration.
Yes, this is technical question. It should be any urodynamic machine, the pressure part of it, where there is a pressure disc, we call it DIS, disc. It should be at the pubic symphysis. So pubic symphysis should be at the same level of the pressure disc on the urodynamic machine.
Okay, thank you. دكتور كان في على السؤال about the cases. Okay, Dr. Muhammad Naji, he asking for case 1. He asked that you repeat the urodynamic study after elevation of cystocele or after repairing of cystocele. If done, what's the result? I think surgery not done yet. صح دكتور أردلان؟
Yes, it's still not done. But what is his question?
Not done, yeah.
Will we repeat the urodynamic?
No, he means that he asking about the follow-up urodynamic. He thinks that you are already did the surgery.
No. We did not do surgery yet. We will do surgery, inshallah, next month.
For case 2, Dr. Malik asking, from the uroflowmetry study and clinical notes, it looks that the findings are going with obstructive cause. Can we try alpha blockers and see the response before we do the urodynamic study?
He already.
In other words, what's the indication of urodynamic study in this patient?
Yes, I already mentioned in the study. I don't know. Can you see my slide now or not?
Yes.
So you can see that this gentleman, he's taking alpha blocker for 1.5 years, and usually most of us, we give different type of alpha blockers, and sometimes also we add 5-alpha reductase to it. Okay, so, and he's not happy with it. That's why this is one of the indication for urodynamic, and because he was scheduled for surgery, so we did a urodynamic. Now, sometimes, many places, because urodynamic is not a cheap investigations. I think usually in Gulf countries, in private, usually they pay around $1,000, if not more, for a simple test, even without X-ray. So here, alhamdulillah, we have everything. This patient, he had also kind of irritative symptoms with his obstructive symptoms. So storage symptoms and voiding symptoms. So that's why, and he was not happy on all the medication he got. That's why it wasn't indicated to do a urodynamic study before undergoing the surgery. I think surgery also was done and everything was fine.
Regarding the same case, Dr. Ibrahim Nadari, he suggested that the management is to relieve the obstruction by TUIP as the size is small.
Maybe. These days, I think we are having an excellent lectures in our urology department regarding different modalities of treating enlarged prostate with minimally invasive diseases. Yes, I mean, there are so many, and we are having a new treatment in our department, which is called Resume. Patient, they don't even go to theater. In the clinic, we do it, and alhamdulillah, the results are promising. And there is a study going on, inshallah. You will have a final result. I don't know, but when.
Also, the same comment from Dr. Ismail Maslami. Also, he thinks that the treatment is bladder neck incision.
Well, maybe, because the prostate on ultrasound is small, we have to scope him. And usually, I mean, if this patient belongs to voiding dysfunction, usually we do scoping. If it belongs to other team, sometimes we leave the scope for them. So sometimes not the enlarged prostate is causing this, maybe the high bladder neck, especially that he's young, 55 years old. So maybe bladder neck incision would relieve him, depending on the cystoscopy finding.
Dr. Abdullah Al-Adimi has a question to Dr. Ardalan that can I proceed management of stress incontinence plus minus TOT without urodynamic study, especially patient without storage urinary symptoms?
Excellent question. This is excellent question. Why? Because according to European Association of Urology and American Association of Urology, urodynamic testing is not recommendation A. So if the patient is not having irritative symptoms, okay, he does not have any dysuria, sign of infection, and you can see with other tests like PAT test, cuff test, Q-tip test, uroflowmetries, plus most important history, you can see that she is having accessory incontinence. You also do vaginal examination. There is no other type of gynecological descent. Then go ahead. You are not wrong. Nobody can catch you on this. You are doing well. If you have urodynamic, that's a luxury. That's enhancement of your momentum of your testing.
Okay, for case 4, the Dr. Muhammad Naji Ubad, he has comment that the detrusor leak pressure point was 44 and low compliance. Despite that, kidney were normal and no reflux. How can explain that the DLPP above 40 and still normal kidneys?
Yeah. See, this patient, okay, he was at the time, from time to time, he was doing, but not regular, CIC. Maybe that was a reason, okay? And 44, so we said above 40 is dangerous. We have seen cases of 50, 60, and 70, okay? So thanks God, he's young, he's 20 years old, and not sure that he will have upper tract problems. Maybe he was on anticholinergics, and that was preventing it from very high detrusor pressure, in which it can compromise the upper tract. Maybe. So not all the cases. That's why I had two cases. You saw both of them DLPP is 40 and above 40, 44. And one of them, you can see that the upper tract is damaged. The other one is not. That's why you need urodynamic. And for neurological cases, every 1.5, 2 years, according to the case, you need to repeat the urodynamics.
الدكتور خالد الكحلاني طالب مداخلة صوتية. ممكن الدكتور خالد الكحلاني you can unmute your mic because you are in the panelist, and you can start, but please to be brief. تفضل دكتور خالد.
Yes. First, thank you for Dr. Ardalan for these nice cases and interesting. Just I have one question or comment about the last case, which this young patient with high pressure and the low compliant bladder, with high reflux on the right kidney. I don't know what was or what will be your plan for this case, but if you are going to do an augmentation for this patient to save the left kidney, are you going to remove the right kidney, or you prefer to keep the Popov mechanism for more protection of the other kidney? Or your plan is quite different of what I am thinking about?
No, I do agree with you. Well, unfortunately, this patient, we saw him only once or twice. So he disappeared, okay? So we did not do any surgery on him, but our plan, MDT plan, was to do an augmentation cystoplasty on him with catheterizable stoma through the umbilicus. And then to see, we could have only left it by itself, not touch it, or do reimplantation because he was young. But how much this reimplantation will save this 9-10% of what's remaining in the kidney? It's questionable. But our plan was augmentation cystoplasty for sure.
Yes, thank you. My second comment, and it is short, maybe about case number 3, which also you didn't give us the solution. I think third case, the lady was mixed incontinence.
Yes. This is tricky.
I don't know, just my question, as she benefit before from Botox injection and was good for, I think, 2 years, why we don't repeat this treatment as a less invasive before any surgical intervention?
Yes. Well, okay, so this is why I'm saying it's a tricky question, because she is having both kind of incontinence with different etiology, and she's bothered with both. Rarely you can find these kind of patients, but this is, and she improved 2-3 years back on Botox injection. I have seen many patients in which they have overactive bladder symptoms. When you treat them, the stress part of the incontinence goes away. So usually also you can find even on urodynamic some rise when they are doing Valsalva, some rise in the detrusor pressure. So I totally agree with you. You have different option in this patient. You can give either, nowadays it's becoming more and more fashion, let's say. You can give either combination therapy of, let's say, the newest treatment of overactive bladder, which is mirabegron, let's say 50 milligram, which is beta agonist, plus a lower dose of anticholinergics, let's say Visicare 5 milligram. Usually they do good. But if not, and you can counsel with a patient, you can repeat the intradermal botulinum toxin injection, and then wait, let's say, 2 months after the injection and see if her urgency part is improved and she's not having urgency frequency, then you can go ahead and do TOT for her, but never do Botox and TOT in the same time, in the same setting. Always try. Most of the ladies, they are more bothered with urgency and not with the stress. Okay, urgency, they cannot go out. With the stress, they can say, I'm not drinking anything, I put pads and everything. So most of them, they are bothered more with urgency. Try always to treat the urgency part of mixed urinary incontinence. There are, I cannot say, maybe 20–30% of them, their stress part also goes away. If not, then you can do a surgical treatment for stress urinary incontinence.
Okay, for case 1, we have 2 questions or comment. Dr. Nabil Muhyiddin, he is asking that he noted that Qmax 9 milli and B-detrosor at Qmax 25, and this is there is 2 criteria for obstruction in female. So he's concerned that he afraid from post-TOT obstruction. This is from Dr. Nabil. Dr. Hussam Abdul Fattah, his question that the patient really need urodynamic study, even we highly suspect the cause of urinary incontinence, that the POP.
Okay. Both of them, they're good question. Let me start with the first one. Okay. Now, if you see at my slide, you can see that here the void is 18 and 15. Qmax are low because, you know, in female it should be above 20. It's lower than normal. Okay. So if you can tell me that this patient is obstructed, I would say yes. And obstructed by what? By cystocele. That's why we are planning to reduce the cystocele. This will take us to the second question, okay, in which my colleague, he's saying that we know the cause of incontinence, which is POP, pelvic organ prolapse. No, this is wrong. Pelvic organ prolapse, anterior descent, or cystocele will never cause incontinence. It causes obstructive symptoms. It causes voiding difficulty and incomplete emptying. Now, the question is, many ladies, and this is a very big debate in voiding dysfunction conferences. Now, if you are doing a surgery for stress urinary incontinence for a lady, let's say, okay? Now, if she is emptying somehow okayish, meaning that PVRs are around 70 to 100, 30, 40, okay? Would you do cystocele repair or not? If you go and check many ladies, especially in our areas, if you check them in the vagina, many of them, they are having cystocele because of 5, 6, 7 pregnancies. You will go and treat all of them? You will do cystocele reduction for all of them? No. You treat if it's indicated, if there are really obstruction, if there is obstruction. Now the question is, Europeans, I think, they only do stress urinary incontinence, anti-stress urinary incontinence, and they put a tape and that's it. They are done, and then they see the patient after that. If she developed urinary retention or difficulty in with high PVR, it is called swan neck. Swan neck مثل رقبة البطة. And then, so they go and repair the cystocele. I think American school, no, they say that anyway, the patient is going under this one. It's better to treat both of them in the same time. And we have a third category of cases also in which they are not complaining of a stress urinary incontinence. They come to you with cystocele, with a big cystocele, let's say grade 2nd to 3rd or 3rd even. Okay, and they're not emptying and they need surgery. Once you reduce the cystocele and you don't do anti-incontinence surgery, they come back to you saying, doctor, now I'm leaking with cough and laugh and sneezing. So this is called hidden SUI, stress-urinary incontinence. It was hidden. She had it, but it was hidden. Once you elevate the bladder, it showed up. So you have to be very meticulous and careful regarding this. In these cases, I do really recommend to do urodynamic for that. Yes.
سؤال للدكتورة هناء. الدكتورة أمل المالكي بتسأل: Can you tell us about the pharmacological treatment of stress incontinence in practice and its effectiveness and some trade names, please? دكتورة هناء معنا؟
أيوة دكتور، سامعيني؟
سمعتي السؤال دكتورة؟
لا تفضل.
It is regarding the pharmacological treatment of stress incontinence.
So the pharmacological treatment is mentioned, but briefly, because evidence doesn't support its efficacy. So especially after the emerge of the sling surgery, which is considered as the gold standard. It's minimal invasive, one-day surgery, daycare surgery. And the only drug that sometimes can affect the stress incontinence is imipenem, which has an anticholinergic effect. So apart from imipenem, in a dose of 25 or 50, there is no other drugs significant in treating the stress-urinary incontinence. I don't know if Dr. Ardalan, do you have other drugs?
Actually, the only approved drug for stress-urinary incontinence, it's duloxetine. And duloxetine is antidepressant drug in the dose of 30 and 60 milligram. Very frequently are given to the patients in psychiatry, and they found out that if they give it in the dose of 40 milligram, it helps for stress incontinence. Many patients we are having who are they have a stress incontinence post-radical prostatectomy who are coming from Germany are giving this drug. I did not see any improvement. It had many side effects. Not all the countries they approve it. I don't know about FDA if it is approved or not. I do not remember. But duloxetine is the only drug which is approved in many European countries. At least I know in UK and in Germany they give it.
سؤال آخر الدكتورة هناء من الدكتور محمد الشميري إنه the patient during urodynamic study is embarrassed, and this will it change the values? How to adapt or cope this?
Yes. So this is an important point because in urodynamic study, we are trying to reproduce the symptoms of the patient in a short period of time. So first, the urodynamic suite should fulfill all the criteria for privacy and for patient's convenience. You should limit, for example, first, before you put the patient on the urodynamic bed, even you have to counsel the patient. The patient should know what he's expecting. We are going to use 2 catheters. You will be covered most of the time. After we are putting the catheters, they are a bit annoyed, but after that, you will be sitting. We will be talking to you. If there is a difference in the gender between the patients and the doctor, we assure the patient, if she's a female, that the male doctor is going to sit behind a certain partition. We try to talk with the patient. Then we limit the access to the room. We try our best not for many intruders coming and going outside. We try when we ask the patient to void, the doctor and the technician, as we can, should leave the room. We close the light and we give the patient a good 4 or 5 minutes to void. However, that all being done, still some patients will feel not embarrassed, but they cannot void because of the situation. The room, it is still not a toilet, a regular toilet. Still he or she cannot void. So We did ask about this in one of our conferences. Some of the urologists, they are giving diazepam for the patient. I've never tried this practice, and not even my supervisor when I was in Canada, so I didn't do it. But we have to remember that sometimes other factors that you cannot control occur. So you have to depend on your guts feeling, and the urodynamic is one piece of the puzzle. You try to read it within the whole picture.
So coming back to case scenarios, and a question from Dr. Abdullah Al-Adimi for the last case, if patient undergoing to augmentation. Dr. Abdullah, he thinks better to use right ureter for augmentation to decrease metabolic side effects and surgical complications. It is a more clinical question, but if you have time to answer this, it's out the scope of the basic course.
I do. This is one of the options, and I do agree with him.
Also regarding the cases,
Shukri, because some cases I put the answer, but till now nobody answered for question number 4, which is interesting, with a 24 young guy with a MMC meningomyelocele, and he had
case 4. There is Dr. Hussam. I think he comment. Yes, Dr. Hussam Al-Fattah, in case of operated meningomyelocele, is really need. His question is really need urodynamic study and will change the plan of treatment.
I didn't get the question.
Yeah, his comment, not question. That is any really need to urodynamic study in such case, because it's already he thinks it's diagnosed.
Yes, he needs urodynamic to follow up to save the upper tract. This is very important. This patient is having low compliance, and low compliance is affecting the upper tract. And by time, I know his kidneys now is fine, but if we don't treat him, then he will be he's for sure the intra-bladder pressure will go up and will affect the upper tract. So my question is that this patient is having low compliance detrusor on cystometry. Again, we are saying that our meeting is about urodynamic, okay? And on pressure flow study, he has underactive detrusor, and he is voiding by straining. So what is your plan for this patient? We just leave him because he's fine and he's on diaper.
All right. You are right. Dr. Nabil Al-Mughallis, I don't know if he's with us. He has question. We can allow him to talk. Dr. Nabil, you can unmute your microphone. Dr. Nabil Al-Mughallis. Okay, if he's not available now, his comment, what's your opinion, Dr. Ardalan, to use TVT, retropubic, in patient with pure stress incontinence with ALPP less than 60?
Okay, so the patient ALPP is less than 60, okay, and to use TVT, I totally agree with him because of many older studies showing that if the ALPP, which is abdominal leak point pressure, is above 100, which, as you heard from Dr. Hanaa, it's indicate that there is hypermobility if ALPP is above 100. If it is low as 60 centimeter water, so this meaning that there is intrinsic sphincteric deficiency, meaning that the urethra is not coaptating good. So it is an open, so the elastic fiber inside the urethra is replaced by fibrous tissue. That's why it's not closing. In the studies showed that if you do a TVT, like a U shape, in these patients with little pulling of the sling, it helps. It is much better than doing TOT, which is better in hypermobility if the ALPP is above 100. Yes, I do agree with him.
Dr. Ibrahim Nadari, for case 6, he thinks bladder augmentation, urethrocystoblast. He agree with Dr. Azimi. Also for case 4, the same Dr. Ibrahim Nadari, he think management, anticholinergic, and CIC.
Yes, very
for
good.
Case 4. Yeah.
Yes, excellent. So this case of this 20 years old, because he has low compliance, but it's only 44, he's not on anticholinergics. So we can start with him on anticholinergics or even give him Botox. It doesn't matter if he doesn't want medication. And to start CIC at least twice per day when he sleeps and when he gets up. But the best way is to do at least 4 times. And always, if a patient any of you having a patient who is doing CIC, always after each, like from period to period, ask him to do something called flow chart. I mean, input-output chart. See how much he's drinking, and on each catheterization, how much he's discharging fluid out. Like this, you can monitor and tell him that how many times he should do CIC per day. Usually, the target of 3 to 350 ml per catheterization, that's a good one. So if it's more than that, he should increase, make it more times CIC. If it is less, he can decrease, make it less CIC per day.
سؤال الدكتورة هناء من الدكتور مالك. Can the urethral catheter size sometimes obscure the urine leakage?
Yes, the size we said that we used French size 8, so it should be okay. However, the presence itself, the presence of systematic catheter, and we've seen it, the patients cannot even initiate any detrusor pressure to void. And the second we remove the catheter, the patient void normally. However, unfortunately, we cannot register the detrusor pressure. So to answer the question, normally, no, the patient can void from around the systometric catheter, but it can happen that due to the presence of systometric catheter, the patient cannot void. Yes.
There is a question from Dr. Muhammad Bakri. He asking me to kindly look at my question about case of VVF posted above. I try to find this. So if we can let Dr. Muhammad to talk. Dr. Muhammad, you can unmute and talk. Dr. Muhammad Bakri.
تسمعني دكتور شكري؟
ايوه نعم تفضل دكتور محمد نسمعك.
Thank you very much for this well demonstrated course. My question is about a real case. I have before about 4 to 5 months, young female about 25 years. She is came with urinary leakage due to vaginal fistula after obstructed labor and cesarean operation in the upcountry. The fistula was about 4 to 5 centimeters. We did for her trans-abdominal trans-peritoneal repair, and she is doing well. Post-operative course is uneventful, and upon removal of the Foley catheter, unfortunately, she is unable to void, and she go in retention. The second day, we did cystoscopy, and the urethra and the bladder neck is open, and we keep the suprapubic for her, and we give trial to voiding for about 1 month. Now she is in the 3rd or 4th month, and she's still in retention. My question: does the what could be the problem with this female, and could Urodynamics will help us to find the cause of the retention in this female? Thank you.
Dr. Ardalan, it is clear. The question is clear for you.
It's clear. I don't know, Dr. Hanaa, you want to answer? Or shall I answer?
Dr. Hanaa?
No, Dr. Ardalan. تفضل. You are the senior. تفضل.
شكرا. Well, okay, doctor. So it was a case of VVF in which it was repaired, and then post-op she could not void. You scope her, everything was fine, and then now it's a fourth month, and still she's not able to pass urine. And your question is, can we know the cause of her urinary retention? Okay, I'll tell you honestly, no. Okay, but it is not absolute no. Well, urodynamic is essential, very important in this case. Now I think by 4th month everything is healed, so it's a good time to do urodynamic. Okay, so you have to do urodynamic, better even to do video urodynamic to see, especially the pressure flow study. Now let's put a scenario that on pressure flow study you will find out she's having underactive bladder, so not passing urine. Otherwise everything is fine. The only bladder is not working, so it's underactive. That's why she's not passing urine. Now, to find a reason for this is a challenge, okay? Because we are also having cases like this. Let's say post-delivery, the patient is not able to pass urine. This can be because of, let's say, trauma to the urethra. This can be because of anesthesia. Can be because of sometimes even I had one case of even psychological. Okay, so but in your case, I add also one possibility that an injury to the nerve, to the bladder happened during the surgery, during the VVF repair. So there are so many reasons for that. But if you do urodynamic, then she has underactive bladder. I think at the end, you have to teach her how to do clean intermittent catheterization. One more thing is that sometimes these patients can benefit from interest in neuromodulation. Okay, they can. I cannot say they will come back to normal, but they can improve a lot. And you know, interest in neuromodulation, it has 2 phases. She can try the first phase. If she has some good response, then a neuromodulator as a stimulator can be implanted for her and see. This is my opinion.
طبعا الوقت هو already time up يعني ولكن في بعض الأسئلة، فهذا يعود إلى السبيكرز يعني إن سمحوا كمان to extend the time، فيعني كرم منهم. Otherwise already the time finished.
المديرة دكتورة هناء شو تقول؟
لا أنا ما عندي مشكلة إذا وقت الجماعة اللوجيستيك إيشو دكتور شكري برضو الله يعطيه العافية مودريتور والسبورت التكنيكال سبورت ما عندي مشكلة. if you want to take another few questions
الكنترول سنتر واللوجيستيك ما عندهم مشكلة يعني يعني متصدقين بوقتهم الليلة، فممكن نضيف كمان 10 أو 15 دقيقة نجاوب بعض الأسئلة.
ما في مشكلة إن شاء الله.
شكرا جزاكم الله خير. Okay. So دكتور مالك أحمد بيسأل is there any difference if the B vesicle is measured through SBC instead of through urethra؟ دكتورة هناء.
أيوة. يعني if was the SBC specifically was inserted for the urodynamic?
No.
Because the old days
patient coming with SBC he means. No, I think he means that patient already coming with SBC and you want to do urodynamic for him.
No, usually there is no problem if the urodynamic machine, if you make if you noted this point and you check the pressure, the vesical pressure, the abdominal pressure, because now there is a difference, and the when you do the zero pressure, something يعني technical issue, but usually no, there is no problem.
في سؤال هو basic طبعا السؤال، بس لفائدة الجميع إنه is there من الدكتور محمد ناجي is there a specific pattern of DSD to differentiate it from bladder outlet obstruction؟
Yeah, so DSD, if I'm suspecting a DSD in this patient, I will make sure that I will run the EMG also. So I will use the patch, the electrode patch, and I will make sure that they are working well before I start the urodynamic. Because the DSD, if the patient has a DSD, there will be a rise in detrusor pressure, that's right. But the EMG will be firing the line and the activity. There will be a lot of activity registered. This means that the patient is trying to void. However, the sphincteric muscle are contracting, and this is DSD. Yes. So if I am suspecting from the beginning that this patient has DSD, I have to use the EMG. I have to put it.
Okay, thank you. الدكتور مالك بيسأل سؤال also basic about the temperature of the fluid installed, if it is it will affect the DO and compliance.
Yes, this is a good question, because usually we use the normal temperature, the normal room temperature when we infusing the fluid during the filling phase. However, in some centers, they will use a warmer because they think that the hospital, inside the hospital, the temperature may be 22 or less, so it will affect the results. And there is one test actually to differentiate if there is, in case you are suspecting the patient has a neurological dysfunction. So you can differentiate between upper motor neuron region, lower motor neuron region, in which the unit, they will infuse a cold temperature normal saline. So yes, the temperature of the infused fluid definitely will affect. However, in cases of the fluid are normal room temperature, usually the effect will be insignificant.
في سؤال من الدكتور محمد مهدي بيسأل if stress urinary incontinence is associated with anterior prolapse, when to do only 2OT and when to do it with anterior repair. Dr. Ardalan.
ما شاء الله دكتور محمد is طبعا one of our best residents, really best resident. ما شاء الله عليك. بس محمد I already mentioned this regarding when I was talking about European school and American school. Okay, so you have to clinically check the patient. Okay, if the patient, what I said, that cystocele usually cause obstructive symptoms. Okay, stress urinary incontinence, the patient is leaking urine. So if you do urodynamic and you talk to the patient, you check the patient, if they have both, then in my opinion, go and repair both in the same setting. Okay, but if you think that the main problem, she's not complaining at all of stress urinary incontinence, and her main problem is only cystocele, and by examination, by all the investigations, you see that there is no any indication of stress urinary incontinence, then you only do cystocele repair, and that's it. And also, I think you counsel the patient, if in the future, I don't see now that you need the anti-incontinence surgery, but you counsel her that if in the future you have it, then we'll do a simple TOT for you, which will not take more than 20 minutes.
حنختم بسؤالين، سؤال مكتوب وسؤال أخير حيكون مع الدكتور خالد الكحلاني. وحقيقة يعني إنه مش عاوزين نطول. الدكتورة هناء من الساعة 3 وهي موجودة في المستشفى، يعني she is not at home، فجزاها الله خير، مش عاوزين نطول عليها، يعني يقال خففوا على أهل المروات. فالسؤال كان regarding the case 3. He is asking why you repeat the uroflowmetry 3 times before the repair or decision to repair. Dr. Ardalan.
Question 2. Why we do 3 times uroflowmetries?
Yeah.
Very simple. See, first time the patient is coming, the area and the situation is not very normal. Okay, so if we do a uroflowmetry and we see that the uroflowmetry is almost normal, we will not do 3 times. Khalas, that's it, once and finish. But if we see once it is abnormal, we try to repeat it. We had patients that first time they came and they saw, because of the situation, because they are not at home, and their voiding on uroflowmetry was abnormal, okay? And then on repeating it, we saw that everything is fine. It's normal. She knows the place. She found that how to do it, and it was normal. So in this case, we do a third one just to confirm that it is normal, and this happens because of the situational issue. That's it. And it's for confirmation. That's it. So doing uroflowmetry for us is easy, very easy.
الدكتور محمد الشميري بيسأل عن ambulatory urodynamic.
Oh, ambulatory urodynamic, we had it in Hanaa maybe 10 years back, and it was not practical. Okay, it was not practical. It's very costly, and I remember we did it for 4 or 5 patients. None of them came with. It was falling out the catheter. So many technical issue we had. Although I remember that when we were doing this ambulatory urodynamic, we bought it. We had somebody from even the company who was helping us to elaborate these traces. But even in the worldwide, they are not using it. So it's very rarely they are using ambulatory urodynamic.
دكتور خالد الكحلاني تفضل.
شكرا جزيلا، وما حنطول عليكم، وقلنا نستفيد من الدكتورة هنا والدكتور أردلان قبل ما يغادروا. سؤالي الأخير كان just about the urethral pressure profile. We heard during the lectures that in many centers already have been omitted and obsolete, and it is still debatable. In some centers, they are still using urethral pressure profile. We want to know what is now the general trend in the most famous schools. Not to use urethral pressure profile, so we're not recommending or asking or buying triple lumen catheters, or still it has any application, even limited. This is my last question.
Good question. Dr. Hanaa, تفضلي. I will also
Yeah, so for the urethral pressure profilimetry, for example, in our center, we are not using it. دكتور حضرتك سألت إذا يعني وين centers تستخدمه. أنا اشتغلت في يعني كان لي الفرصة إنه قدرت أشتغل في 3 centers خارج قطر، وال3 centers ما بتستخدم اليوريثرال بريشر بروفايلومتري. مثل ما قلت لك الاي سي اس، يعني كل ما سويت ريفيو الانكونتيننس سوسايتي كوميتي سوسايتي of incontinence، كل ما بتسوي ريفيو there is no strong evidence support its role. This is number 1 in diagnosing الurethral coaptation، او زي ما قال الدكتور أردلان intrinsic sphincteric deficiency, and it needs a specific technique to do it. So the nurse or the technician who is running the test should register in 2 points, while the catheter, it comes with a balloon, so you have to reach to deflate and move it forward, then move it again forward. You have to measure the pressures and check the difference. So especially in adults, it doesn't give us payback for that hassle, for which, for example, here in Qatar we are not using. I worked in Canada in 2 centers, they are not using, and in Germany with one of the founder of the European guidelines for the EAU, also he's not using. So Dr. Ardalan, what do you think about this?
Yeah, I agree with you totally. I think it is used mainly in the big centers in which they are doing researches. I think they are using it just to know what is maximum urethral closing pressure by UPP, how much it has clinical influence on your decision. Not a lot, I think. Especially even in female is even more difficult. Female urethra is only 4 centimeters, and the striated muscle, it's in the middle. If it is damaged, then okay, you can measure the UPP of this damaged sphincter in female, but at the end, a clinical value of it, it has no, it's only for just diagnosing, and usually you can omit all this. If you do many simple urodynamic tests, you will get to the same result. Maybe some people they are using, and I'm very interested in post-surgical prostatectomy incontinence, and maybe it is useful in that part also. But again, I'm telling you, we are not using it. It has many difficulty with the pullers of the catheter, and it is not good. One more thing, just I want to also put a point about DSD, the detrusor sphincter dyssynergia. As Dr. Hanaa said, it's very important to diagnose DSD. It's not easy, okay, because you have to see the striated muscle and the smooth muscle, which is also responsible for continence in the bladder. And recently, I just read a paper that you can do this by putting these patches. These patches represent indirectly the striated muscle of the sphincter. And you have to do video urodynamic when the patient is voiding by continuously just taking pictures and see the bladder neck, which represent the smooth muscle. And with, let's say, with the clinical history, you can suspect that this patient is having detrusor sphincter dyssynergia or detrusor external sphincteric dyssynergia, and usually which happens, let's say, in MS patient, for example. But with UPP, I totally agree, Dr. Hanaa. I think we have it, but we are not using it.
شكرا جزيلا. قبل ما نختم بس أثناء المحاضرة تكلمت أنا عن الفيميل يورولوجيست في اليمن، وذكرت اسمين الدكتورة عائشة، الدكتورة أروى السلامي، الدكتور خالد الكحلاني جزاه الله خير، نبهني ل4 أسماء الآن ما شاء الله فخورين بهم، يعني الدكتورة عائشة، الدكتورة أروى السلامي، الدكتورة أمل البشاري، والدكتورة مروة المنصري. أتمنى أنهم كلهم كانوا معنا واستفادوا من الكورس. في الختام الشكر الجزيل الذي لن يوفيكم حقكم للدكتورة هناء، الدكتور أردلان، أيضا الفريق الذي يعني عمل بشكل قوي جدا لإنجاح هذا الويبينار، الدكتورة مريم العمادي جزاها الله خير، وهي الدينامو المحرك لهذا الأمر، وأيضا فريقها العامل معها الدكتور عيسى الحر جزاه الله خير، والذي أيضا بالأمس أعطانا محاضرة عن الزوم، وأيضا فريقها الدكتور بناتها أسماء وفاطمة الحر. الشكر موصول للدكتور عبد الله النعيمي، الدكتور خالد الجلهم، الدكتور خالد الرميحي، الدكتور خالد الكحلاني. الجميع شارك بقوة لإنجاح هذه الفعالية. أتمنى أن تكون الفعالية قد يعني حققت أهدافها، وأتمنى من الزملاء أن يقوموا بتعبئة أو ملء أو السيرفي الذي سيرسل لهم بالإيميل، لأنه السيرتيفيكيت سترسل للمشاركين اللي سجلوا، وأيضا ملأوا السيرفي. أثناء السيرفي أيضا ستكون أسئلة عن الكورسز اللي يحتاجوها مستقبلا، وأعتقد أنه الدكتور أردلان والدكتور هنا لن يقصروا في advanced courses، ويعني بالطريقة هذه أنه تعبناهم في البيسك فيتم الجميل، زي ما يقول المثل اليمني، يتم الجميل يا جميل. إن شاء الله يكون في advanced courses. شكرا جزيلا لكم جميعا، ونستودعكم الله، والسلام عليكم ورحمة الله وبركاته.
وعليكم السلام ورحمة الله وبركاته. شكرا.